is there? Hello. Let's get going. Looks like we're getting a good quorum here. Oh, we're just admitting people left and right. Wait just a second. Okay, welcome. Quality Health Outcomes Committee meeting, QHOC. We have Lisa Bowie here. We're going to get going right away. We have a kind of a full agenda. We have a learning collaborative as well today. Dr. Dawn Montner, I thought we were taking the morning off. Apparently she's decided to do a little bit of work today. So she's going to stay for a little bit, I think. Surprise. Let's go ahead and do just a couple of reminders for the meeting. As always, when you're not speaking, please remain muted. You have that little microphone icon, your telephone button down on the bottom to unmute your line. When possible, use the reactions button to raise your hand on your Zoom bar on the bottom. And at the beginning, please try and say your name and your organization when speaking. And if at all possible, it's lovely to see faces, so turn your camera on. Let's go to the next slide. Just as a reminder, so Zoom technology tips, you have the Zoom bar at the bottom, just went over the mute bar, the video bar. We are recording and there is the chat function. We have Jennifer and myself helping. So if you have any technology needs, just drop a chat and we will try and help you throughout. Closed captioning is also available, and that's the CC live transcript button at the bottom. Next slide. Jeannie, do you have any announcements, or Dawn, since you're both on the line before we get going?
Not from me, thank you. You're just watching me eat peanut butter and jelly. Apologies.
Okay. I've got my peppermint tea. Dawn, what about you?
Glad to be able to join for a few minutes this morning, and appreciative of the work that happens in the dialogue that we are able to have. There are a few updates. This transition over the course of this next month is into a new phase of work as our Healthier Oregon program shifts into its new phase of welcoming about 12,000 members to full coverage who have previously only been eligible for emergency services, which is a big and exciting opportunity, and which is going to require some additional support. That's a lot of people, and there are also people who, in many cases, may have been without coverage or care for a good while, and because there's a transition in their enrollment, as there is with every enrollment, for people who are gaining OHP coverage to spend a few days or weeks in the fee-for-service program before their enrollment in CCOs is completed and they transition over. So that onboarding is always challenging, I think, potentially, but this is a particular moment when our those who have formerly been covered only by column or citizenship waived emergency medical coverage are now going to have access to full care. So we appreciate the collaboration both with OHA and with KeyPro to do that as effectively and with warm handoffs as possible. Similar challenges will apply with transitions for our
the Sandy Hook kids. I mean, Adam Lanza.
Morning.
Thank you. With our the pregnant members who have OHP plus, who will get extended coverage out to 12 months postpartum. for that same group, even if they're not in the covered age ranges. So that's some excitement that I wanted to share. And there's one more exciting note on the policy front that I wanted to share, which is about doulas, who have an incredible both return on investment and impact on equity and impact on outcomes, maternity outcomes, as well as babies, and supporting more extensive use of their services and access to their services by proposing a rate increase. So we'll have some information about that. Welcome. Good morning.
Thank you, Dawn. So it sounds like there's some information coming out about doulas, and it sounds like there's some information coming out about the Healthier Oregon for individuals who will be now covered through that benefit. So stay tuned for those policy options information. And then let's go ahead and go to the next slide. Jennifer, please. Okay, here's the agenda. We're going to have a brief conversation about OUD, SUD, telehealth. Dr. Carr, Doug Carr, your chair, and I will kind of tee that up. Then we're going to carry forward. I missed May's QHOC, so you all carry forward. But what I heard was we may ran out a bit of time around the telehealth, or not, around the BUPO prescribing OUD, SUD. So I believe some of our pharmacy team, as well as John McElveen, our state SOTA, will be coming to continue that part of the conversation. Then we'll go into the HERC update with Dr. Ariel Smith. Then we'll have our break. Then we'll go talking about childhood immunizations, learning collaborative, kind of coming out of the pandemic and kind of teeing up for what we know will be kind of a, we have to, get going on immunizations. Then we'll have a lunch, and then in the afternoon quality performance improvement session, we'll carry forward our SUD statewide performance improvement design conversations. And then we will also be talking about national diabetes prevention technical assistance needs discussions for CCOs. So that's the round robin for today. Any questions, conversations before we go right into it? Okay, next slide. Well, let's just go back a slide since I don't have really a slide for the, Dr. Carr, do you want to tee it up or do you want me to tee it up?
So one of the issues around substance abuse treatment by telehealth is the issues in our own Oregon administrative rules, as well as the federal CMS rules, which have been waived during the pandemic. And those rules require that anyone using telehealth for mental health, ongoing mental health or substance abuse treatments have a physical relationship to the patient, that they are available. They either initiate the initial visit with in person, or that is accessed by the individual. That is one of the questions that we have, and so in the area of MAT in particular, part of the challenge has been to find is to have an adequate network within our CCOs regions to be able to identify, we may have some federally qualified substance abuse treatment programs. They operate under federal rules, and particularly for methadone, it has required some, in-person taking of the medication. And part of the challenge is being able to see where telehealth is involved with taking care of both MAT as well as mental health treatments and services, while still trying to maintain the adequacy of and the workforce within our regions. So in other words, part of the challenge has been there are some national players. One was Cerebral, and there was an expose in the Wall Street Journal this last a couple of days ago that indicated that they had there was a clear-cut over prescribing of Adderall and other ADD medications. They're under federal investigation for said approaches. They deposed their CEO, and they've done some reorganization. And the article indicated that they're reorganizing, and they think that the next growth area is Suboxone. It's really a Wild West type of situation out there, and trying to sort out the players, both responsible perhaps and some that are on the edge, and how to have those players at the same time as trying to support and have a program with our CMHPs and other people that we have relationships with in our network. So I think that's part of the challenge. And right now, it appears that the OARs don't allow us to have our members seen without the availability of an in-person visit. So that's the, in the context of this is there have been some burn grants that have been announced by the 110 measure commission, and some of them have involved virtual buprenorphine MAT prescribing. So that's just the issue.
No, yeah, and let me just make sure I want to make sure I clarify what the concern from the CCOs are, and this is a fielding of information, and Doug is speaking on behalf of UHA, and I'm assuming, and Speak Now, again, this is not Speak Now Forever Hold Your Peace, but this is so I can gather the information and make sure I get it back into the agency. And Doug has brought this up on behalf of the CCOs. He brought this up, I think, back in April, just FYI, and we just didn't have time on the agenda. So this is, he raised it again. And I think Doug and Jeannie, as your chairs, have brought this in, and we want to make sure we understand the issue. The conversation is that based upon CCO interpretation of OAR, at least one OAR, we don't have to cite it right now, that the telehealth, in light of a public health emergency in current state, basically, that the individual has to have, the member has to have a visit in the state of Oregon, brick and mortar, in a clinic. Is that what you're saying, Doug? Like they have to have a visit?
That's what the OARs state right now.
Clarification, I thought the public health emergency did away with that requirement. And so during the public health emergency, that requirement was overridden. And with the public health emergency going away, the question is, what is the state of Oregon going to do to reconcile this issue? And how are we going to, as providers of Medicaid benefit, making sure that we're following the rules correctly?
Yep. Okay. Yeah.
Correct.
So during a public health emergency, you didn't need to have obviously in-person, because obviously we're in a public health emergency. But when the declaration goes away, is the state of Oregon still going to require on-site for telehealth? And if so, obviously CCOs don't want to be, breaking the law, and therefore you want that guidance. And then how do you appropriately respond to these national players in regards to, you know, some of these particular providers? And then obviously you have concerns in regards to some specific providers.
Well, especially in the light of the fact that the grants were awarded to providers who don't have brick and mortar, is what I understand, in the state. And so some of the burn grant money was given to 100% telehealth providers. And yet if the OAR says they can't practice here without a brick and mortar, that seems to be contradictory. So how are we going to reconcile that work as well? And then I think what the other issue is on the clinical side and the quality side and the member advocacy side is, how do we ensure that these services are following standard of care and that we are providing the best service to our members without causing harm?
Okay. I've got a bit of those notes. Anything, and thanks, Dan, for putting the comments in the chat as well.
And the OARs are 410, 120, 1990. 410, 120, 1990. That's where providers who offer telehealth services must also offer in-person services. And then there's there's also one around provider directories, which much includes street address, the provider's location. And that's 410, 141, 3585.
And Lisa Bavesh has his hand up as well.
Bavesh, you got the floor.
Yes, hi. Can you hear me okay?
Yeah, we can, Bavesh.
Okay, good. My question is also related to that. And I'm not sure if I'm correct with this, but network adequacy does not allow for telehealth only providers as being counted towards the percentage that we need to achieve for network adequacy. Am I right with that, or is that incorrect? And if that is the case, then if we're going to allow telehealth providers to be in the network, why wouldn't it also count towards our total percentage network adequacy?
Bavesh, I'm not even going to try and answer that one, but I wrote it down.
Okay, thanks.
And Lisa, for the information also to go kind of as part, I think it would be important to look at the recent Oregon Medical Board, which did come out with a statement of not purpose, but overall intent of telehealth in the state of Oregon. The most recent Oregon Medical Board had on page 8, and I can send that to you if you want, Lisa, to look at. So you can take that back for discussion.
Yeah, I think, because I mean, what we're talking about is, because I mean, first off, the state of Oregon we don't credential. Obviously, you guys credential, right? So then there's a little bit of mix of this. And what you're bringing up is the OMB, which is a little bit about credentialing, right? So it's a provincial. So send me the page 8 thing. But we've got OAR, which is how the requirements of what a provider can do, but then you've got the guidance which relates to the licensure, which is probably what you're talking about with the OMB, which you all in the CCO land care about, because you're the ones that have to check it against the licensure, which we can only tell you to do via your contracts, right? Which ultimately you have to do it, not us, which is where there's in my past life, I cared about because I did credentialing. But in my current life, I don't really, do credentialing. But I care for you guys. So send it along, and I'll share that with some of the folks here at the state. And so I'll show them the OMB stuff. But I think that's kind of where part of that information and what it means to those individuals. And then to Deanne's comment about about OAR and the public health emergency and all that stuff. That I don't do RACs, Rule Advisory Committees, but Health Systems Division is, well, either way, the agencies have to review all those kind of things when the public health emergency ends. There's a whole bunch of stuff that will have to happen. And I know there's a whole group of people looking at that. So Deanne, that conversation is currently happening, probably across a whole host of things, not just this particular role. So I'll put this one in the mix, but what we wanted to do is to have the conversation. Doug and Jeannie had already raised it. We just need to find, one, the time, because we always have lots of agenda topics, and then two, find all the competing many parts to this that I can bring into the agency and say, okay, here's the parts to this conversation that relate, not just when the public health emergency ends, here's the issues now, here's after the public health emergency, here's how it relates to OMB or credentialing part, here's how it relates to the contracting, and then here's the quality side of it, which is access, quality of care side of it, and here's part of it that is just around the OAR part of it. And so I think there's two parts. There's the credentialing side, which is all your business, right? But then there's the OAR part of it, which is public health emergency, what needs to happen pre and post that, and what does the rule need to say pre and post that, which is where we can step into that space and form and have that conversation. Any other for the good of war on this one before? And Ariel, can you put in the chat how long you actually need for your HOOC update, just since we're running tight. Thank you, Ariel. She's always just so good on the timing.
Hey, Lisa, looks like Dr. Qureshi has a question.
Yep, go ahead.
Hi. So,
hi, Safina.
Hey. So, thanks for that overview, Lisa. And my question is, when I agree with all those parts, and I just want to, I think you all are well aware of this, and so not to be redundant, but I feel like that OAR was written in a different world, and we're now, like, I get that it was, we're in emergency and it was removed, and in the rest of the universe of our existence, telehealth is a different entity than it was before the pandemic. And that's one of the benefits, I think, of what COVID brought to us. There's lots of horrible things, obviously, but so when you say have that conversation, what do you mean? Like, where is that conversation and when is that conversation? Because I think it hugely impacts our ability to strategically plan for the future and closing access gaps and how we're interpreting that OAR. Is it cut and dry, or is it that you have to have care coordination in place and close linkages if it's a telehealth only provider? And so I think that there's like nuances of that conversation, but I'd love to advocate for having that conversation sooner rather than later. And the only additional thing I'd say is that it goes beyond just SUD. Like, there's a lot of gaps in services across the board in all types of care that telehealth potentially could close, that if we're not able to look into those opportunities, it's going to, affect the future for our members. So,
Safina, you're 100% right. And Don, I'm going to get to you. And John McElveen and Andrew Gilbler and Dee, there's most likely not going to be a conversation about OUD buprenorphine, and we're probably going to have to table that to July. Just FYI, just putting that out there. But here's the deal. Bhavesh raised the Telehealth Oregon Health Leadership Council Best Practice Toolkit. There's two toolkits related to adults and pediatrics that he wanted to bring forth to this group. So one, there's some best practices related to telehealth. That's from a practice side, right? Then there's this whole OAR, how we interpret the implementation of, I guess you could say, the construct of how we can implement those best practices related to telehealth. So one of the conversations that I have been thinking about with telehealth is how we have that here. One would be in July, we're going to have the best practices come to this meeting. Most likely, we might have to have a learning collaborative related to telehealth. The other thing is telehealth and what we do next with telehealth related to the OARs and the changes, which again is up in Don's shop in Health Systems Division with the Rules Advisory Committee. Those Rules Advisory Committee conversations are not yet happening because we're still in a public health emergency declaration, whatever, right? So those timings of when those will be with whatever happens with the public health emergency timing, and Dawn can maybe speak to that. But it relates 100% to access, which is 100% under the quality realm, and it's not specific to what Doug and Jeannie brought, which is the OUD, SUD, which happens just to be one provider type. And I know Doug and Jeannie weren't speaking to just the one provider type, but telehealth is all with, and so that's why this is just one tiptoe into this conversation. Where we go with this is related to access broadly. And so this is just a step into it, which I've already brought this attention to Dawn, Dave Embody, quality assurance team who owns Access. And so I appreciate that, Safina, because you just reinforced what I already brought up to them. And so this feedback here will only reinforce that. And Dawn and I will be going back with them and figuring out how much of July will be all telehealth, honestly. Dawn?
Thank you. This is an issue and has been an issue for a long time. And a lot of dialogue has gone back and forth between and among the CCOs, no doubt, as well as between CCOs and OHA. And there is a memo teed up that will be coming out shortly with more information for CCOs about the intent and plans that's coming now down the pike, and also there will be a RAC a little later to discuss specifically what needs to be happening. We can't wait until the end of the emergency to discuss what we're going to do at the end of the emergency, and so I appreciate the urgency and the ever increasing sort of pressure as two things happen. As the end of the public health emergency approaches, even if it has been pushed off a couple of times or continued past impending deadlines, and also as we all figure out more about what we can and can't do with regard to incorporating telehealth, both AV, audiovisual, and telephone only care into our practices as a more robust and potentially convenient part of our delivery of health services. And I want to acknowledge something specifically about equity here. When we first started piloting telehealth visits at Jefferson in Philadelphia in about 7 years ago or 8, in my family medicine practice there, we were sure that this was going to improve equity. This was going to make care available to people who didn't have transportation, who didn't have to take whole half days off of work to come in. And there certainly is the capacity and the potential for that. We've also seen some worsening of health inequities as a result of telehealth. And for example, providers will say, we won't see you in person the first time, we're going to do intake over the phone, so that people don't have the choice of what kind of care they are receiving at one time or another. And so best practices and ways to be sure that the new technologies are integrated and built in a way that improves equity is high on our radar and our agenda, just like it is for you. And so I will look forward to those conversations about how it can be built in a way that improves equity and doesn't exacerbate or worsen existing inequities, including use of best practices that are only now beginning to come out in these last couple of years, and especially now that we've been practicing with it for this last couple of years with the pandemic. So acknowledged, we need to figure this out. You've been asking for a long time. Dialogue is happening. There will be a rec. You'll be receiving a memo, and I'll look forward to where we can take it the next step in upcoming conversations. Thank you.
Okay, so I'm going to round out some next steps. So yes, this might have been brought up by your chairs as a OUD, SUD provider related to telehealth, but my inclination was that it's telehealth broadly and it does relate to quality and access. So we are going to be talking about it related to telehealth as a quality and access conversation. You are getting a conversation around a memo and how it does relate to public health emergency. We will be talking about telehealth best practices because the Oregon Health Leadership Council already brought out a toolkit around telehealth best practices. That's around the quality of telehealth and how to implement it in your practices with primary care. Then we'll talk about telehealth, related to the administrative side, route, credentialing and the contractual, the OARs and all the stuff. Then we'll talk about telehealth, the actual, network side of it. There's telehealth quality, telehealth administrative, and telehealth, network. So there's like telehealth, at least 3 buckets. There's probably even more, but that's kind of how we're going to approach it for the time being. And that's not any one discipline. Behavioral health, physical health, oral health is like everything for right now. If there's anything in any part of that you don't like, or you want to say, hey, I really want to address specifically XYZ, then you be sure to get that to Jeannie and Doug. And they will say, hey, Lisa, before you bring that back in July, make sure you address this. Because that's what we're planning on for July at the very least. And I know I already have the OHLC, the Oregon Health Leadership Council, teed up. So that's for sure. And I know I have the access team in quality assurance teed up. So that's already also done. So there we go. Any other questions? I've already talked about to John McElveen offline as well. We are going to table the buprenorphine OUD diagnostic conversation that left over in May. We're going to not rush that. We'll bring it back in July when we don't have a learning collaborative, because we don't want to, again, butt up against that and shortchange that conversation. So we will most likely bring that when we don't have a learning collaborative month. So we'll be bringing that back into July. There's nothing necessarily actively urgent about that. So we'll give it its due time and bring that into July. Thank you, pharmacy team, for being flexible. We will invite you in July for the carry forward of that conversation. Ariel, you are on deck. You get the 20 minutes and then we'll go into break before the learning collaborative. Thank you for being patient, everyone.
Hey, Lisa, just really quickly, it's Jeannie. Want to make sure that Dr. Qureshi, that your hand is still up. Just want to make sure that your question was answered.
Yes, sorry, I'll take it down.
Okay, no, it's all good.
Great, thank you.
Good morning, everyone. Are we ready for me now, or are we still? Okay.
You're good to go.
For those of you who don't know me, my name's Ariel Smits. I am the medical director for the Health Evidence Review Commission, and I'm bringing you the HERC update for June. Next slide, please. One day when we don't have a public health emergency, I won't be having slides every meeting about new COVID codes, but that's not there yet. So there are new codes for the Sanofi GSK vaccine. I believe that might be going to the FDA soon for approval. So for the vaccine and for the booster dose, those will go on line 3 if they receive an FDA EUA. And then there is a new dose, or a new code for a booster dose of one of our current vaccines here. And it's going on line 3. The tri-sucrose, that's you've seen the earlier, the non-booster doses for that. Next slide. And then we have a couple of HCPCS codes for monoclonal antibody injections. So this is a pre-exposure, so this will be ancillary, and there's 2 doses of it. Next slide, please. And then again, another monoclonal antibody will be ancillary. And then the actual HCPCS codes for the injections of these monoclonal antibodies will go on the COVID line, which is $3.99. So you can see the drug itself is ancillary, and all of the different flavors of infusions are going to be on line $3.99. Next slide, please. So that is the new COVID codes, and hopefully they will stop coming. But for the time being, I expect that every meeting I'll have a few of those to show you. They are effective as soon as they are published, unlike other CPT codes. So just for your own awareness that you need to have them open, unless they don't have those codes, the vaccine that doesn't have the FDA EUA yet. But as soon as it gets an EUA, if it does, the code will be open. So for May, I went through at our last meeting all of the topics that were coming to the meeting. In the packet, you'll see all of the minutes from BBBS and from HERC, so you can look at the final decisions. Pretty much most things were decided as we discussed at the last meeting, sort of kind of going along staff recommendations. There were a few minor changes. We did add chronic renal failure of kind of all flavors, not just end stage, to the erythropoietin guideline, but we added a clause that you have to have adequate iron stores before you can give erythropoietin, otherwise it doesn't work. So I don't know if that needs to change any of your PA criteria. You can see the guideline wording in the minutes. And then for BAHA, which are bone anchored hearing aids, we had a guideline where we sort of clarified our indications for the actual insertion of the bone anchored hearing aid portion. At the meeting, there was desire to clarify that we continue maintenance of these types of hearing aids after age 20. So if someone has a BAHA inserted at age 5 and they're now 30 and they need a new whatever battery or whatever, that should, as long as it's working well for them, that should be continued. We discussed Panda PANS, that's the post streptococcal neurologic disorders or post infectious neurologic disorder syndrome. The HERC accepted the EGBS recommendation to cover IVIG for this indication, but they did not include plasmapheresis in their final coverage. If you look at our minutes, you can see the entire guideline that would go with when a patient would qualify for IVIG. Next slide. So those were the major changes. Otherwise, you all heard sort of what the staff recommendations were last time. So, and if you have any questions, look at the minutes, and of course, send any questions to me or to herc.info after you've had a chance to look at the minutes. For August, our big topic is always ICD-10 codes. I saw a preliminary, and there are some crazy number like 1,500 new ICD-10 codes out there. So if anyone gets them early, let me know. I know that they were in the Federal Register about a month ago. So we have a preview of what they're going to be, but there's a lot of them. There's some clarifying that we do cover medial and radial nerve injuries. There's a question about that. We had a question about acupuncture for substance abuse therapy. So the question here was, so acupuncture by itself is not a treatment for SUD, but it is a adjunct that can be really helpful for people who are going through withdrawal or going through medicated assisted treatment, et cetera. And we had said in the guideline that they needed to be in a drug treatment program with a broader variety. And that's been apparently interpreted somewhat strictly, that you have to be in a formal program. What the HERC intended was that just that the patient is in some type of broader therapy. So they don't necessarily have to be in a formal program, but they do have to have other things on board, whether it's talk therapy or medication assisted treatment, et cetera. Our tympanostomy guideline, there's a pediatric ENT who's brought forward the new AAO 2022 guideline, which includes a few extra sort of high risk group. So these are kiddos who have like a hearing loss developmental delay. We already have most of these groups as sort of exceptions, people with kids with craniofacial anomalies, et cetera. We're going to be adding a couple of minor groups. For example, children with like blindness who are relying more on hearing, et cetera. Autoimmune encephalitis, this is sort of tailing along at the end of the PANDAS conversation. Autoimmune encephalitis was part of the PANDA-PANS review, but it was determined to be a completely different entity. Typically it happens when you have like a brain tumor or something. These people are incredibly ill, they're in the ICU. They do need plasmapheresis, IVIG, et cetera. It's unclear currently whether we cover this. The code that is most used will be moved to a covered line with a guideline saying that that's what it's there to be used for. Most of these people are probably ICU level care, so we're already paying for them through DRGs. So it's probably not a big coverage issue. We've been asked to look at human growth hormone for adults or people with closed bone epiphyses with Prader-Willi syndrome. That this improves things like quality of life or cognition. We have not been able to find a lot of evidence supporting this, but we'll bring this discussion to the meeting for a formal discussion. I'm continuing to work with a podiatrist and a orthopedist who works with feet on some of our foot deformity coding and what we need to cover. Hopefully that will be ready in August. And then one of your CCO colleagues has asked us to look at Cpap titration. So what kind of coverage do we have, for example, for sleep studies, et cetera, for Cpap titration? So we're working on that, and that hopefully will come in August. I'm going to stop here for any questions before I go on. Hearing none. Next slide. So the continuing our August agenda, our scoliosis guideline, we had a question about some of the criteria there. We'll be looking at autologous chondrocyte implantation. This is a knee procedure, and I've been working with orthopedist about some clarification of some of our coverage. Indications for surgery for tethered cord. This may or may not actually need to come to August. I think we actually are okay with what we're currently covering, but that's currently on our preliminary agenda. And then for our 2024 biennial review, we've been asked to look at disorders of sleep. The main one there would be insomnia, because of good evidence that cognitive behavioral therapy helps insomnia. Fortuitously, P&T is also doing a review of medications for sleep that will hopefully be done before August. So we'll kind of bring that as a package to see if we need to change coverage. We've also been asked to look at our current lack of coverage for TMJ. My preliminary look, there are multiple Cochrane reviews of various types of therapies. None of them seem to be very effective. So we're probably going to recommend not moving TMJ. But again, this is kind of in the works for August. Next slide, please. So any questions about HERC topics? Obviously, it's only mid-June. We have at least another month where we will be collecting questions and topics. Of course, you all can get in touch with me or with HERC.info with your questions or any other issues that you want HERC to consider. We're always happy to hear that. So moving on to the evidence-based guidelines subcommittee, they met in May. And they looked at the high frequency chest wall oscillation coverage guidance again. This had been sent back from HERC to EBGS because of some concerns about the lack of evidence for bronchiectasis. So the initial EBGS coverage guidance had said to cover for CF, bronchiectasis, and neuromuscular disease with pulmonary complications as long as people met certain guideline criteria, but not for COPD. Then based on the weakness of the evidence for bronchiectasis, they were actually looked at that again. We looked at it again in May. There is real paucity of data regarding bronchiectasis, but we had several experts in the field come and testify and help. the subcommittee, they, based on that expert input, added back in coverage for bronchiectasis when you have a productive cough, which is not the case for many people with bronchiectasis, and you have frequent exacerbations requiring antibiotics. And that you have to try or fail or not have available other therapies. I'm still working with the experts to see exactly what those other therapies will be. You know, it's probably home physical, chest therapy, perhaps medications, etc. So we are still finalizing our blue box wording, and that will come to HERC because EBGS's intent is pretty clear. We just need to clarify the exact wording. The cystic fibrosis and neuromuscular disease sections will continue to be recommended for coverage, and a continued lack of recommendation for coverage for COPD. Any questions about the chest vests? Next slide. And then going back until, this actually should say May, sorry, typo. It wasn't April. We discussed the scope statement for continuous glucose monitoring. This had been brought to us through the governor's office. So the HERC had reviewed continuous blood glucose monitors based on a med report. We reviewed it in October of 2020 and did not find evidence that they were sufficiently effective for any group other than type 1 diabetics. We were asked to look at this again. The Center for Evidence-Based Policy did some preliminary looks. There's really not a lot additionally available since their review that came out in January of 2020, except for one JAMA article that was included in our HERC review. So the suggestion was to table this for another year or two until there hopefully will be more studies published, because we felt like it was not a good use of EBGS's time to dig into continuous blood glucose monitoring if there was already a pretty up-to-date med review, and in a few years it will need to be updated. So for now, we are continuing to limit continuous blood glucose monitoring to type 1 diabetics. And obviously you, as a CCO medical director, could make exceptions for type 2 diabetics in certain situations if you felt that that was appropriate. Next slide. So the future topics, EBGS is currently looking at bariatric surgery. We approved a scope at HERC at the last meeting. So we are looking at all types of bariatric surgeries. The change in scope compared to our review many years ago was that we are going to look at adolescents for this. We are also going to look at outpatient settings. There are some of these procedures, some of the ones that aren't quite as intensive, are being done in outpatient settings. So we'll look to see what settings we want to cover this in, whether it's appropriate for adolescents. We currently limit it to 18. And also if there's any comorbidities in addition to what we list in our current guideline. So that review will hopefully be discussed at EBGS in September. But again, anytime you have any topics that you think are appropriate for an in-depth coverage or review, we are delighted to hear about it and would love to have you raise them with us. Next slide. So these are all the ways to get in touch. HERC.info is probably the best. It will always get to a person and then be dealt out accordingly to whoever is most appropriate to answer the question. And I just want to remind you all that we are super happy to have Amy Cantor as the second medical director. She's going to be working on Mondays and Tuesdays, so you may be getting some responses and interactions from her. She's going to be mainly responsible for EBGS going forward. Again, feel free to reach out to her if you have an EBGS question. Any questions or input or things that you want to bring up in general for HERC issues? So I guess it was less than 20 minutes even, Lisa.
You just got this HERC update down. I don't see any hand raised, so if you have any questions for Ariel, you can go off mic or off mute, or use your reactions button to raise your hand, or you can email that HERC questions inbox and she gets back to you, or Daphne or Jason or Amy will. Okay, so what we'll do is we'll go ahead and take a big long stretch break. We will reconvene at 11 o'clock sharp for our Immunizations Learning Collaborative. Please remember to keep your line on mute, and we will see you back here at 11 and start the Learning Collaborative. So we'll go on break. You can go ahead and advance to the next slide, I think, or yep, the break slide, and we'll see you here shortly. Thank you.
Okay.
Welcome back, everyone. Jennifer, if you wouldn't mind, go ahead and proceed a slide forward. Thank you. Okay, so we are back. We're going to go ahead and begin with our learning collaborative for getting back on track with childhood immunizations. I am Lisa Bowie, the Quality Improvement Director for OHA. I'm going to continue to, Jennifer, if you wouldn't mind trying admitting people, since I'm going to go ahead and do the welcome and introduction. Thank you, Laura, for getting this going. Let's go ahead and advance the slide. So I'd like to thank Laura Krieger from the OHA Transformation Center for getting this transformation or this learning collaborative going. When we were talking within OHA about which learning collaborative would be really timely and talking with the quality staff of CCOs, it really seemed that childhood immunizations was really important to get back on track coming out of a pandemic, or we're still kind of in the pandemic, but what could we do in a timely point with where we're at, but also where we know we need to go and where the CCOs are at, and you know, where the summer is at, and kind of prepare for coming back into school. So childhood immunization seems really the most advantageous, as well as kind of getting the children prepared and preventive and upstream approach. I wanted to kind of go over the agenda and also introduce the panels and the support staff that we have for this learning collaborative. So the agenda we have teed up for this afternoon is kind of the welcome and the overview. We, as always, will kind of overview the actual metric and where we are in our performance. We do recognize that the performance is, you know, impacted obviously because of the pandemic. So we will highlight where the numbers are, but do know that obviously the pandemic has affected those numbers. We will talk about obviously the impact of the pandemic, and then we're going to give some tools. So we have the immunization program from OHA to come online, and we have some communication strategies, and then we'll have CCO strategies and some clinic strategies, and then we'll end some time with some discussion, and hopefully we'll have enough time for that discussion. On the panel today, we have Sarah Kleinschmidt from OHA, one of our senior policy advisors on the metrics team. We have Andrew Parker, our research analyst in OHA on the metrics team. We have Steve Robeson, our immunization surveillance epidemiologist from the immunization program. We have Susan Wickstrom, our immunizations communications coordinator. We also have specifically for our CCO strategies, Elke Geiger is the director of Pacific Source Columbia Gorge CCO. She has prior experience as a practice coach for the CCO, where she worked with clinics on improving CCO metrics. She has a business operations experience in specialty medical clinics, as well as in community and specialty mental health and addictions clinics. Her additional professional interest spans the fields of organizational development, data visualization, cognitive psychology, and program evaluation. And then to round out our panel, we have Dr. Jay Rosenblum, who is a full-time pediatrician at Pediatric Associates of the Northwest, medical director of the Children's Health Alliance and Foundation, and a volunteer and presenter for Boost Oregon. Thank you very much for all of our panelists who have prepared and actually brought these resources to you all here at CCOs and for the broader audience at large. Let's go ahead and go to the next slide. Let's just remind which particular, there's several childhood immunization metrics. Let's kind of ground ourselves in which particular childhood immunization metric we're speaking to. I'm not going to read the full which one we're speaking to. I'm just going to round it and say we're speaking about the combo 3, which is the percentage of kids who are up to date on vaccines by their 2nd birthday. And just as again, a reminder, we at OHA measure this particular one by checking the state immunization registry, otherwise known as the Alert Immunization Information System. And we check whether the child has had their immunization by 2 years old and is enrolled in the CCO and have had all their vaccines. And again, we look at medical claims submitted by their healthcare providers. So again, we check the alert system, we look at the claims, and we do that for individuals by their 2nd birthday, basically. So combo 3, alert system, medical claims, that's the basic gist. You can look at all the little details below that. Next slide. And for all the presenters on the panel, if you want to go ahead and say next slide or say Jennifer. Jennifer is our support staff who will be advancing slides for you throughout this learning collaborative. Sarah, you can go ahead and proceed with all the little details on the actual metrics and their performance. Thank you all. And Sarah, you've got the floor.
Thanks, Lisa. Hi, everyone. My name is Sarah Kleinschmidt. I use she, her pronouns. I am the lead staff for the Metrics and Scoring Committee, and I do a lot of work on our CCO incentive program. And I'm going to go over a very few slides about the incentive measure around childhood immunizations. And I want to note that I am joined by my colleague, Andy Parker, who is our analyst who works on this measure and knows the ins and outs of coding related to this measure if you have any detailed questions like that. Andy can jump in. We'll move to the next slide, please. So Lisa went over the measure at a high level, but I want to point out a couple really specific things related to it. So today we're focusing on children who turn 2 during the year. And while the measure focuses on this age group, I want to be clear that we know CCOs are working with and are responsible for ensuring all kiddos in this age group are up to date with their immunizations. For the measure, we only look at kids who are turning 2 in the measurement year, who have been enrolled in the CCO for at least 12 months before turning 2, though they could have one gap of up to 45 days. So for example, if a child turns 2 on the day after they enroll in a CCO and isn't up to date in terms of vaccination, certainly the CCO will work with that child and their family to get them up to date, but it wouldn't be appropriate to count that child in the metric. That's not the work that can be done in one day. In addition, in terms of how we know kids are up to date on their vaccinations, you'll see that on the slide, we've historically looked only at the Alert Immunization Information System, but something I'll go into in more detail on the next slide. Beginning this year, we are supplementing the Alert IIS with information from Medicaid claims for things like disease history. Next slide. The measure that we use is essentially owned by the National Committee for Quality Assurance, or NCQA, as referenced on this slide. And NCQA, the National Committee for Quality Assurance, creates the details and the technical specifications for the measure. And in previous years, OHA has made deviations from those specifications. And NCQA allowed those deviations from its technical specifications in the past, but moving forward, including for 2022, we need to calculate the measure in strict alignment with those specifications. And those changes are described in the measure technical specifications. Andy was going to post those in the chat, so you all will have that link. Andy, if you can do that, that would be great. And then there is a link on this slide to a memo that also goes over those changes in detail. And as you'll see described in the memo, the changes are in both directions. So some of the changes will result in lower rates. So for example, you can see on the slide that the National Committee for Quality Assurance is no longer allowing the use of combination 2. So from 2022 on, the measure uses combo 3, which means that pneumococcal has been added to the set of vaccinations that the measure tracks. And we know that that will result in lower rates, at least at the beginning. And other changes, things like looking at disease history and claims, will actually increase rates, so that we have an apples to apples comparison of CCO improvement. We're going to run 2021, which is the baseline year. We will run that year again using these updated specifications, and that is what we're going to use to set targets for 2022. And again, these changes are described in the memo that is linked on this slide, and then also in the technical specifications, the link which Andy's going to post in the chat. Next slide. And Lisa mentioned this, and I know colleagues from the Public Health Division are going to talk about the impact the pandemic has had on immunization rates. And certainly we have a lot of work to do together to improve immunizations overall. But you also know that the agency is focused on eradicating health inequities. So we thought it would be helpful to look at performance on this measure in terms of equity. So this slide shows measures that count kids. And in some cases, like ED utilization at the top, they count kids and adults. But all of them at least count kids, perhaps supplemented with adults. And these measures have all been included in the incentive program, either in 2018, 2019, or 2020. So an asterisk means that they were incentivized in 2018. The caret, or the upside down V, means it was incentivized in 2019. And the sword thing, I do not know the name for it, means it was incentivized in 2020. So we took those measures that count kids and have been included in the incentive program at some point from 2018 to 2019. And we calculated the observed racial disparity in 2020. So if you look at the numbers to the right of the bar for each measure, That's the average percentage distance to the mean, which is the unweighted average of all groups' percentage distance from the statewide average, which you do not need to digest all of that. What is important to understand is that a higher number means that the disparity by race and ethnicity is worse. So if you look up second from the top, that is adolescent immunization. So that's looking at immunizations for 13-year-olds. And you can see that the observed disparity there was 20.9%, which is worse than for childhood immunizations, which is highlighted, where you can see that that is at 9.8%. That said, there are still disparities for childhood immunizations, which are best shown on the next slide. So this slide shows data specifically for the childhood immunization measure for 2020 by race and ethnicity. So these are kids turning 2 in 2020 who were enrolled in a CCO for at least 12 months with one allowable gap of up to 45 days. If there were fewer than 30 children for a specific racial or ethnic group, we suppress those numbers to ensure confidentiality. So that's why there isn't a number for Middle Eastern or Northern African children. So in terms of what you're looking at, if it's a shade of orange on the left, then that means that performance was worse than the statewide average. And if it's a shade of blue moving to the right, then you'll see that performance for that racial and ethnic group was better than the statewide average in 2020. So you can see here that immunization rates for Native Hawaiian or Pacific Islander, as well as Black or African American children, are lower than the statewide average. And I didn't include a slide for adolescent immunizations, but it's interesting to see this in comparison. Because if you look specifically at the 13-year-olds, and actually overall, the trends that you see here are similar, but the lines get bigger because the disparities increase. So while for 2-year-olds, Native Hawaiian or Pacific Islander children have immunization rates that are 4% lower than the statewide average, Native Hawaiian or Pacific Islander adolescents have immunization rates that were 40% worse than the statewide average for 2020. And that trend continues on down. So that was quite interesting, and I hope some kind of helpful background for the conversations that you'll have today. If we go to the next slide, this just gives you the email address for our metrics team. If you have any questions about any of the incentive measures, whether it's about specifications or about how the program is run, this email address is monitored by multiple people, and we're happy to answer your questions. I'll pause now.
Dr. Rajani, Lisa, is it okay for us to take the questions now? Yeah, okay, go ahead, Bhavesh.
Yes.
Yeah, thanks. Sarah, the question that some of us are wondering about is there still a perceived difference in achieving metrics this year through the pandemic? Or are things, where are we at compared to where we were last year? Is there like a way to measure how patient access has been going compared to previously in general? And how is that difference being, kind of followed?
That's a good question. So we're actually working on finalizing final performance for CCOs for 2021. Our team was working on that last week, and we will be sending CCOs, CEOs their final performance and payment amounts for 2021 at the end of this week. And then we will be publishing, hopefully in the next month, a report so that folks can see overall how CCOs did. And what we're working on this year as well is creating a dashboard that folks can go into and look at past performance as well as up through 2021. And that we're looking for publication in the autumn. And that will allow these deeper dives into race and ethnicity and language for these measures to help with these conversations. In terms of setting performance targets for the measure, The metrics and scoring committee will be having those discussions at the end of the summer. And so for that, we will be including the final performance through 2021. That's what we have at our disposal for those conversations.
Great, and it looks like Graham has his hand up now.
I'm also going to note that, hey, Graham, our next presentation also has current statewide data comparison across the years. So if your question has a data question, Graham, we may want to hold for the next presentation, which has even more data. So I'm going to let you think on that and then put your question out.
Maybe I'll launch in, and if it seems more appropriate for the next thing, we can hold it. But if we wouldn't mind going back a slide that shows the racial groups. So I think the earlier slide showed like a 9% difference from the mean. Is that right? Within this measure, how is the unknown category included in that calculation? And I think everyone who's looking at enrollment demographic data under OHP recognizes what a large proportion of the population that is, and especially for young children. I think it's disproportionately large compared to the rest of the population. So is that 23% seen as a group that is variant from the mean, or is it excluded in that calculation?
It's a really good question, Graham, and you are correct that there are, in the raw data, there is a large proportion of unknown race and ethnicity. But for this analysis, we actually use supplemental data, including race and ethnicity for folks who are receiving other public benefits, to fill in some of those places where race and ethnicity was unknown. This is something that was presented to the Metrics and Scoring Committee. It is what we call our deeper dive dashboard. And there is a whole FAQ document on that in terms of the methodology used for how we did that. So actually the unknown was actually relatively small. But as you're saying, it is still, you can see that there is a disparity for that group here. I can't speak to the heterogeneity or not of that group.
Okay, and but that group at a 23% difference was included in as one of the non-weighted groups to get to that 9%. Okay. I wasn't part of the Metrics and Scoring Committee discussion. I must have missed that one. And I'm sure that there's others on the call who did as well, but it certainly is interesting that there's another source of race and ethnicity data that's being used for calculating these types of things. I commend the state for doing the work to put that together, and then would just sort of make a blanket statement that anything that could be shared with CCOs would be really helpful, because we spend a lot of time really struggling given that lack of clear information on our end. It's been years of a problem. So it's very hard for us to have high, both personal expectations around being able to do equity work, as well as community expectations around being able to do that, with one of our main data sources being so flawed, frankly. So again, commend you for folding that in. And I know, Sarah, this isn't all on you or Lisa or anything, but the quicker that we can make that part of our CCO strategy, I think the better for all of us for having these kinds of conversations meaningfully.
Right, and we will have the dashboard that I mentioned with the final 2021 performance, and where folks, CCOs, can go in there and dig and look back. That will include breakouts by race and ethnicity. And all of this is a bridge as we get to the SOGI and RealD repository that is being built by our partners in the Equity and Inclusion Division.
Great, and Lisa,
Jackson,
do we have, oh good, just making sure we have time for one more question there.
I see Jackson's hand, and I'm going to ask Jackson's hand, is it related to Sarah's data set, or is it related to a future data set conversation?
It is a very quick follow-up to Graham's question.
Okay, go for it. And then we're going to probably go forward in the next data set questions, and then I'm going to round it up and go to the next one. Go for it, Jackson.
Great, thank you. This is Jackson Ross with YCCO. Sarah, you said that the unknown category here was a relatively small group. Did I hear that correctly? in this data set. Can you give me an approximate idea about how small? I just want to compare that to our own unknown population and see how well this maps onto what we understand about our membership.
Jackson, I can't remember the exact. Let me check with the analyst who works on it, but I know there was a huge drop, but I don't want to throw a number out at QHOC and have it be incorrect.
Fair enough. Okay, thank you.
So what I'm going to do for those that were not at metrics and scoring when we presented this deeper dive report is I will touch base with Sarah. We'll bring it into a QPI session. I will also link that report, which talks about the methodology that OHA did do in trying to bring a whole host of data sets into that deeper dive analysis that was trying to bring in, again, multiple data sets to get into, let's say, lesser unknowns in regards to that race and ethnicity, so that we did have a smaller unknown analysis. So I will put that as an action item, because it sounds like some of y'all missed that one, and when it got presented to metrics and scoring. So we'll round that up, and that's outside of just this immunization conversation, but it sounds like that's how it got identified. And then we will, Jennifer, if you wouldn't mind advancing 2 slides, please.
Hey, Lisa.
And then yes.
Sorry, I don't mean to interrupt, but I think there's a clarification that is important to go forward that does not have to do with the next data set before we push forward. And I apologize for slowing you down. I want to make sure that it sounds to me from kind of the questions and the discussions previously and what we're hearing now, that there is an assumption that access to care for children and childhood immunizations has improved from 2021 to 2022. And I guess going forward, Sarah, my question would be, and I think the question that Bhavesh was asking that I'm not sure was answered was, how is the OHA looking at access to care and using or evaluating, whether it's utilization, et cetera, that access, and then utilizing that in the formation of the targets going forward? Is that going to affect the targets going forward? And Bhavesh, if I spoke incorrectly, please. But I don't think that question was answered, and I think that's something
that's a different question. I think Sarah didn't answer. Sarah, am I misspeaking there?
I can answer. I tried, but apparently I didn't answer their question. So yeah, in terms of 2022, how CCOs are doing in 2022, that is not something that we don't have validated data for 2022. We send CCOs quarterly reports on how they're performing, but that is not validated. We have a whole validation process after the close of the year. That will not be until 2023. What the committee will be looking at in terms of setting this target is trends from 2019 to 2020 and then to 2021. But you are correct, they will not be looking at 2022 data because we don't have finalized data, final validated data we don't do that for quarters. We do ask CCOs as we send them their quarterly reports to please look through, send any validation questions to us. However, experience is CCOs often don't send that to us until the end of the year. And therefore, anything that would be a partial year should be treated with extreme caution. And we wouldn't share that with the committees for that reason.
And then part of that decision making with the metrics committee, the metrics and scoring committee, is that there are certain assumptions that then go into helping make those targets. And what I'm saying is that those targets, assumptions about access to care through 2021 and 2022, have those need to be clarified with the metrics and scoring committee. And I don't know how that's done.
The target setting for the actual metric is not a conversation we're having here.
Totally get it. I totally get it. I just want to push that concern forward to the committee. Sarah can take back to the committee. We don't need to have that discussion
that's all
today.
Yeah, Sarah's heard you, and Sarah will do that.
Great.
Kat, does yours relate to Sarah's data?
Yes.
Okay, well then we can talk about it. Otherwise, I'm going to let Steve talk about his data, which you'll have more questions once you see Steve's data. Steve, thanks for waiting. Kat, you can ask something about Sarah's data.
Well, I wanted to tie it into a larger request for an action item, which is that this work is incredibly important and we are very hampered with our equity work because we do not have good real data. And so, you know, for example, this is a little bit older, but our kids, you know, under 5, like half of our kids, we don't know their race and ethnicity. And so we are trying to do really fantastic equity work, and it's really hard because our data is very flawed. And so it's super exciting to hear the ability to, you know, look at other data sources and kind of lower those numbers of unknowns that OHA is working on. And so the request is, it would be fantastic if we could have a work group to really talk through, you know, what are the current real data sources. Primary care is doing this now, OHA is doing this as part of this, and, you know, the supplemental things that you all are doing, which are very exciting. But we would like to have a discussion about what are the ways to really improve this real data so we can do better, more informed equity work.
Well, the good news is, like Sarah has alluded, the Equity Inclusion Division already has some tangible work already underway. The deeper dive report that Sarah has alluded to that has already been published, the deeper dive dashboard, that was an interim. Basically, we mushed a bunch of data sets together to make this deeper dive dashboard, right? So we literally took a bunch of things from a whole bunch of sources, but that, you can't even imagine the amount of work that probably took to validate that this one individual from all of these data sources is the same individual, right? But then once you do that, then you have a richness of this one individual is one human, and this now has all these other different data points that were probably in however many different data sets, which now we, you know, they might have had unknown different fields and other different data sets, but now they're less unknowns. Yay, less unknowns. So now, but we didn't, you know, we did that for a particular dashboard. The Office of Equity Inclusion Division is trying to work on a more longer term solution to that, obviously. And that is where we have come and talked at the QPI session on that pathway that the Equity Inclusion Division is going, the trajectory. And so we can have them come report on that again. Caller. So that's, oh, thank you, David. We can have them come and talk about it again and what that kind of the steps and what that update might look like. And then I'll also separately have the deeper dive report come and talk about that methodology. So you at least have the context of that dashboard. So when you dig deeper into that deeper dive dashboard, you have the context of that methodology and what that unknown really represents. So there will be 2 action items at the very least. So just hang tight with me, and Kat, if you want to email me about what that looks like, feel free. Okay, Steve Rosen, you are just getting teed up because now you can see you got a bunch of data-minded people on this call. So you get to go dig deep into the immunization data, and you just get to, you know, pull those bootstraps up and present the data and get ready for the data questions you got coming your way. So let's go ahead and go, Steve.
I'm a little sorry. What I have here for you today is a brief overview of how we've been tracking pandemic effects on routine immunization. So if people have more questions and want more data, we've got a lot more. But, you know, just as an overview, you know, obviously the pandemic led many clinics to reduce access to routine services for some short period of time, and parents became more reluctant to bring children in. So we saw an initial steep drop in immunizations at the start of the pandemic, but we expected that these would recover fairly quickly back to the pre-pandemic levels. And to track the effect and the recovery at the start of the pandemic, the immunization program picked 7 sentinel measures of month-to-month activity, you know, because you can't really track up to date, you know, at age 2 on a month-to-month basis, since it really is based on immunizations given over a 2-year period. It doesn't reflect current volume and what's going on each month. And we didn't pick all the immunizations that are due. We just picked a set that would give us each month some idea of how that overall delivery of immunizations was taking place in the state. So the ones we picked to look at were infant DTaP immunizations each month for children between 2 to 9 months of age. So that would include the first 3 DTaP, but the 2, 4, 6 month visits. Rotavirus at ages 2 to 7 months, because you can't really catch that up. That's a good indicator, though it's outside of the regular immunization up-to-date series. We looked at infant MMR at 12 months of age, childhood MMR per month for children from 2 to 9 months of age. That would include the children receiving the second MMR for school entry, as well as some late starts on first. HPV immunizations per month at 9 to 13 years of age, Tdap per month at that same age range. And we did a total number of immunizations per month for infants from 1 to 24 months per age, and more importantly, it's not on here, but a number of immunization visits per month. So go ahead and advance a slide. And we actually have a dashboard of this. It's kind of, I think it's a little clunky. We were racing to get this out at the start of the pandemic, and it's too much information for one page. We're going to redesign this and get this out on a 2-page basis, I hope, soon. But this allows selection of county, it allows selection of the measure, and it allows looking across 4 years from 2019 before the pandemic up to the current. We also have data on here, some summary data that includes race and ethnicity as we have it in the Alert IAS. And I have the link to this at the bottom of the page if people want to go and play with it. What I was going to present today is just some summary information on a couple of measures to give some of the flavor of what we've been tracking and what we're concerned about, what we've been seeing. But this is yeah, feel free to go and look at this dashboard if you want to get more detailed local or any more specific information, including on race ethnicity. So let's go ahead, advance one. So the problem, we saw that initial steep decline in routine immunizations with recovery starting after a few months. And it depends on, the adolescent series took a little more time to recover. Infant recovered to a much quicker degree, but we don't see a complete recovery to pre-pandemic immunization levels yet. And the only way I can describe this, why don't you go ahead and click it, is we got housed. It feels like, yeah, we were the necessary extra character in the Wizard of Oz here. We did not expect this not to recover completely and quickly. So go ahead and advance one. And just for context, it's not just Oregon. Other states have reported the same. There was a recent national conference with presentations detailing very similar patterns to what we see here in Oregon from Michigan, New York City, California, and we've had communications with at least another 3 states who've been tracking it closely that all show the same thing. The CDC became aware of this problem fairly quickly too, and has been tracking it through their national data sets. And they've published 3 MMWRs, that's the morbidity weekly reports. And those 3 include a drop in vaccination rates among kindergartners that they just came out with, an overall US immunization decrease, which was that came out last year, and a global immunization decrease. I'm actually co-author on a couple of these. But so we're seeing this as a problem. It's Oregon, it's national, and it is to some degree international. That in the wake of the pandemic, we are not getting back to our normal immunization levels, which is going to lead, if we are going to keep rates up there, it's going to be far more of a burden on catch-up, as well as, how do we get back to normal levels is a question. But I want to show you a couple things from here. Go ahead and advance one that are from Oregon. I'll show you a couple of series. This is the HPV immunization at age 9 to 9 to 13 by year and month. So we're doing a month-to-month comparison, where 2019 would be the baseline, pre-pandemic. And this is the number of HPV immunizations given by month. If people wanted more information, we can split this by which shot in the series it was, but just total volume is for sentinel tracking is our starting point here. So as you can see, in 2019, the light blue line, it per month followed along. We peaked up in August, prior to going back to school. We always see certain immunizations peak up in August before the teens go back to school. And then proceeding into 2020, at the beginning of 2020, the rates were going up again. We know we had a lot of QI efforts out there, and I think they were bearing some fruit. And then in March of 2020, the blue line, you can see the big drop start and then the huge drop down into April of 2020, a little bit of recovery starting in May, and then June, it looked like it was going back to normal. That seems to have been a little bit of an illusion. I think we had a little catch up there going on too to boost it up, because it's been bouncing up and down since then. Looking at 2021, you can see 2021 started trending down again. And then 2022, at least for the first 4 months of this year, have been also dropping back down again. We had a little recovery in early 2021, but we're not seeing that in 2022 at all. And it's a real question, since we see such a big boost in HPV rates when we go into the summer months, and traditionally, are we going to see that this time or not? I don't know. But go ahead and go on one more. And here's infant DTAP at 2 to 9 months of age per month, and this is the same month-over-month comparison, where there's a little less variation. I think that there was far more emphasis on getting the infants in for visits and shots, but still we do, when you compare, you can see the drop that occurred in 2020 was far less. There wasn't that much of a drop. But now when you look at 2021 and then to 2022, where we currently are, we're not back to pre-pandemic levels, and it seems like it's staggering along on the state level altogether. So why don't you go ahead, one more. And this is immunization visits per month for infants age 1 to 24 months. It's a repeat of the same type of pattern, where you can see there was a very slight drop during the initial months of the pandemic in 2020 in March and April, then some recovery. And where we currently are is that it seems to be, again, running at levels that bounce up and down a bit, but it's generally a little bit less. It's comparable to or less per month than we were pre-pandemic. Like if you look at current last data, March of 2022 was looking like a good month, fairly comparable to pre-pandemic, and then April is back down again. We're seeing some of this bouncing up and down, but overall it is in collectively running less. So, catching the kids up is going to be a challenge. It's not just, well, we have to do the catch up if the normal base number of immunizations that are given on time is down. That's more work for catch up. And we'll go ahead and advance. And here's where I get to hand it off to my colleague, Susan Wickstrom. Unless you wanted to take questions on data before we go.
Yeah, let's before we go to communications, maybe we'll go data, because those are very different kind of topics. Are there questions around kind of what you were seeing in the data? We got one right there. Graham, you've got the floor.
Yeah, Steve, that was very compelling, and I appreciate the visualization. It makes it easy to see. Can we go back a slide or two for a second? It's a fairly basic question, and I don't question, I'm not questioning the premise of what you're presenting here in terms of a reduction in immunizations, but does this adjust? This looks like it's a raw count of immunization visits per month. So does that adjust for a reduction in the number of children? I mean, were there corresponding reductions in number of births, either in OHP or broadly during the pandemic that might, is there any way to adjust basically for number of opportunities? Again, I don't question the premise. I'm sure that the rate as a percentage of eligible children has gone down, but when you're just looking at a raw count of number of visits, clearly that would be impacted by the number of children. So I'm just curious if that's folded in.
And that's a very good question, an intelligent observation, and the birth cohort in Oregon has not gone down. I kind of thought with the pandemic we'd see a drop in births, and apparently not.
Yeah, I thought I had seen fewer pregnancy folks in the pregnancy rate category for CCOs during that time, but maybe I'm wrong. Thanks.
The overall state, it's staying fairly stable. Plus, also the population. You know, if you want to talk about older kids, like if you're tracking immunizations among teenagers, that's not going to be influenced by the birth cohort, unless we knew that there was more kids in that age range moving out of state than in. We wouldn't expect it to be much change, but we don't seem to really have any data that we've had real differential mobility. If anything, mobility has shut down some in the pandemic and post-pandemic periods.
Thank you.
We'll go to Jay next, and then Jackson, you're after that.
Steve, I think it was about 15 years ago, you guys published the Oregon Vaccine Hesitancy Index. Is that work has that been repeated in the last few years?
Thank you, Jay, for your very long memory. That work has not been repeated. There have been some other parties, both there was a WHO-sponsored group that did some hesitancy work. You know, the University of Washington researchers have continued on with some of that, but in general, it's kind of lagged. And we'd like to get back and repeat some of these things, or at least some of the tracking of behavior. You know, such as the number of kids that are getting limited shots per visit or have late starts. But no, we have ourselves not done that.
And Jackson, your question?
I have two separate questions. One is a quick follow-up to Graham's question. I know that, so you said that there wasn't a raw, right, a meaningful change in births over that time. I know at least we at YCCO had a significant change in our membership, and I don't think I've ever heard one way or another if there was a huge change in the number of people on OHP generally across the state, and if that might be something that would need to be factored into those numbers. So maybe I'll leave that question first and get that answer, and then I'll ask my second question.
This is for the entire state population, not just the Medicaid population, because yes, we knew there've been a lot of shifts in membership and clinic usage and other things. That's why we were a little hesitant to drill down onto smaller levels.
Okay, great, thank you. My next question is about the incentive metrics themselves. I know looking back at our own metrics performance and here at YCCO and how those services have been given out over time. If you look at the metrics, so just take childhood immunization combo 2 for last year, which is for members who turned 2 during the year. The vast majority of those services happen in the year or two before that metric year. So, you know, you're going into the year with something like 85% of those vaccinations having already been given out, the ones that apply to that membership. So if we're looking at, you know, metric year 2022, you're talking about a period of time that really covers the pandemic, essentially. And so we're going to be experiencing the effects of that for the next several years for the immunization metric. And I'm just wondering, maybe you're not the right person to answer this, but I'm just wondering how much that is being taken into account in our rates going forward.
I'm not the right person, but we put out rates for the state populations, you know, 2-year-olds, adolescents. We put those out for the whole state, and we're looking at the same problem, which is it's a lagged effect. So if the bulk of the impact on a current rate is from several years ago, it's really hard to move that very much. And so we're seeing potentially some small drops in the rates we're going to publish statewide, but I can't speak for the Medicaid component.
Okay, thank you.
Great, thank you. Let's go ahead and move on to the next presentation. Let's communications. We'll go ahead and go from communications, and then we'll go straight into our next presenters. Thank you, Steve. Susan, you're up.
Thank you. Thank you for having me. I'm Susan Wickstrom. I am the communications coordinator for the Oregon Immunization Program. I started at OHA in 2009 during the H1N1 response. And I've just had a variety of communication roles in public health. So I'm going to share some resources for immunization providers to promote routine vaccines. And I also want to kind of give you a big picture of vaccine communications in general. So switching from our left brain maybe to our right brain. Next slide, please. Some of you may have read a recent article in the New York Times Sunday magazine about the anti-vaccine movement. I've got a copy of it right here, and I'll send a link to Lisa so you can take a look at it. It's really long, but they do have an audio version that takes about an hour to listen to. And so you can listen to it during your walk. Steve mentioned earlier how the pandemic kept parents from bringing their kids in for routine shots. And this article offers some very compelling anecdotal evidence on how the COVID infodemic is negatively affecting routine immunization uptake. So it's really worth reading. It's really good. One of the biggest threats to all vaccination right now is misinformation. So both the CDC and the WHO, World Health Organization, have made this issue a priority and are providing intensive training to immunization communicators to help staunch this mad overflow of misinformation, which they call an infodemic. Both organizations are working furiously to provide education and training around the world. So the CDC has designated vaccine demand strategists in every state who are getting training and resources. And then starting at the end of June, the WHO is conducting a month-long training called, and I'm going to read this because it's a mouthful. The training is called Comprehensive Training for Promotion of Vaccine Demand to Maintain and Restore Routine Immunization and Promote COVID-19 Vaccination by Leveraging Social Data, Behavioral Insights, Infodemic Management, Service Experience, and Digital Strategies. So yeah, try fitting that on a business card. But they believe that high immunization rates are important steps towards global health, and they're preparing to vaccinate the world. So I'm participating in both of these training efforts. I'm Oregon's vaccine demand strategist. And in my upcoming WHO training, there are 550 people from 72 countries, many of whom will be deployed to under-vaccinated regions to educate on vaccine safety. So I hope I can share, and I plan to share what I learned in both trainings to improve vaccine confidence at Oregon and to help achieve OHA's goal to end health disparities by 2030. So I'm starting with this slide to remind all of us that one of our best tools, best communication tools to combat the infodemic is spreading evidence-based pro-vaccine stories to friends, relatives, coworkers, neighbors, and basically anyone who will listen, both in person and on social media. So this picture here is sort of a how it started, how it's going meme. On the left is my son Griffin in 2017, a few days before he left for college, getting his second dose of meninge B and a flu shot. He had his HPV series when he was 13, so I felt he was pretty well protected to go live in a dorm. And you know, parents have enough to worry about. So when you send your kid off into the world, it really helps to know that they're fully immunized. And then the photo on the right is his graduation day a couple weeks ago. He got through it. He got through college healthy. And because he's used to being vaccinated and knows the benefits, he was excited to get the COVID-19 vaccine. He actually didn't let anybody in his house unless they had the vaccine, what they called the Fauci ouchie in his crowd. So it doesn't matter if you're a clinician, a policy setter, or just a human being. keep spreading those good, true personal stories, no matter how small or irrelevant they may seem, because we want to create a pro-vax culture in Oregon. Next slide. So OHA has some communication strategies to promote routine immunizations across the state. Of course, this week, everybody is hyper-focused on the COVID-19 vaccine approvals for the littlest kids, ages 6 months to 5 years, which will be arriving in Oregon a week from today. Super exciting. This is the last age group to roll out, and we are fully aware that immunization providers are exhausted by the last year and a half. And you know, we're tired too. I don't think I need to expand on that. But from a capacity perspective, OHA has been sort of living large with COVID-19 federal funding to increase staff and support deliverables. So the immunization program has taken the opportunity to shore up our processes and teams. And now we're transitioning back into a steady state with the opportunity to address some neglected issues. And as Steve showed us, we know kids have fallen behind in their routine immunization schedule. So we are planning a routine immunization catch-up awareness campaign in August, just in time for school. And it's also National Immunization Awareness Month. So we hope that those kids will get caught up as quickly as possible. And of course, we've been talking about data this whole time, but as public health folk, we know the importance of data to inform us where the gaps are in our immunization uptake. And our Alert II system is one of the best immunization registries in the country. And through that system, we can determine which communities need outreach, and the reminder recall can identify which patients are behind in their routine immunizations. Boost, I know Jay is a member of Boost. That is our statewide immunization coalition, and ORPRN, or Oregon Rural Practice-Based Research Network, are conducting training for healthcare providers, by healthcare providers across the state that take a motivational interviewing approach. And we know that providers have really been wanting some training on vaccine confidence. I had the opportunity to observe one of these trainings, sit in, and they're very good. They're excellent. So the Oregon Immunization Program is planning a roadshow for the fall. We're going to 7 regions across the state, and we will offer this training option to participants. So the roadshow is part of our vaccine demand strategy. We're also going to generate earned media. We are working with OHA communications team to pitch some mainstream media's news stories about the importance of routine immunization. And we know misinformation is spread most quickly through social media. So we're countering that information with real stories that will reinforce Oregon's social norm that by far, most people immunize their children. So OHA's social media team is participating in CDC training to address and halt vaccine misinformation that they encounter in social media. Next slide. We do have some existing resources to help providers promote routine immunizations in their communities. Our OHA website has some good information materials. The Oregon Immunization Program has weekly office hours on Mondays at noon, and led by Wendy New, who is the public health nurse, and she answers questions and presents the latest vaccine information. She also brings in some really great speakers. I mentioned our routine catch-up campaign coming in August, and in the meantime, we have several trusted partners who have developed excellent toolkits just jammed with all sorts of helpful resources. And I'll just kind of fly through these. The next slide is Health and Human Services has a Catch Up to Get Ahead toolkit. Next slide, they have great materials. These are their key messages. They have just pages and pages of talking points that are super helpful for providers, for anybody to be able to talk about routine immunization catch-up. Next slide. The American Academy of Pediatrics has a toolkit aimed at getting kids back into the office. Their hashtag is call your pediatrician. So that's, they've got some really funny videos on there. And next slide. CDC has really improved their materials in the pandemic. I mean, seriously, they've really stepped it up. So they've got some great immunization resources, including the social media card. I know that Steve Robinson really loves this picture. So, and just a reminder that all the CDC materials are public domain, so you can use anything from the CDC website, and they have a great photo library. So that's a great resource. And then next slide, the Association of Immunization Managers has culturally appropriate materials in different languages. This is Spanish. Your healthcare provider is prepared to safely vaccinate your family. Don't wait, call today. Next slide. The Immunization Action Committee is a repository of resources. They have webinars, articles, policy guidance, infographics from facilities and experts across North America. There's a lot out there to promote immunizations, get families back into clinics now. So next slide. We all know that vaccination is one of the greatest public health tools to protect our communities and keep people in Oregon healthy. So thank you all for your hard work, and we'll be in touch through our provider listserv. And if you need anything, just let me know. Thank you.
Excellent, Susan. Thank you so much. This is Jeannie stepping in for a minute for Lisa. Do we have any questions for Susan right now and some of the materials that she has presented? I don't see any hands coming up. Just a reminder to anybody who is on the phone or listening to please mute if you aren't speaking. And if you do have a question, it'd be great if you came on camera, but not mandatory. All right, excellent. Susan, thank you so much. I believe next we go to Elka is up next to give our next section.
Thank you very much. Hi, I'm Elke Geiger. I'm the director of the Columbia Gorge CCO for Pacific Source. And what I'm going to do today is walk you through kind of a brief history of immunizations, childhood immunizations in the Gorge. So what we did pre-pandemic, what we observe now, and then what we're trying to do about it. Next slide. Yeah, it's really strong. But I just let it go and it'll... So once upon a time.
Okay, I apologize, but we still have somebody not on mute, and we're getting a ton of, I don't know if everybody else is, but I'm getting a lot of feedback in the background. I'm trying to figure out who that may be, but please everybody mute if you are not speaking. Great, Elke, I apologize. Go ahead.
Thank you. All right, next slide, please. So pre-pandemic, we took some pretty tedious but very effective approaches to figuring out gaps in our vaccinations. So first of all, we send, and we continue to do this now, member immunization gap lists to encourage proactive scheduling. Sometimes we organize those, they're in an Excel format, we organize them in a way so that we might highlight or put in red font to really alert the clinics, kids who are turning too soon, to try to get them to make those calls. Not a perfect approach because there's often a bit of a delay in getting information from the alert IIS, but those work pretty well. We also did and continue to do monthly feedback to all of the clinics that are participating, that are part of our provider network. We report the data regularly to the Health Council and the Clinical Advisory Panel. And then lastly, what we did is looked at child by child status of immunizations. So by member, if there were any gaps, what that looked like. Next slide, please. I felt I did a lot of this work. I felt like an archaeologist. It was extremely tedious, but really what we were looking at is what's going on at the individual child level, and then to try to aggregate that data so we could see, were there any opportunities that we could start to influence our rates. A lot of what we found was there were avoidable misses at the time. So I think I did this in 2017 and 2018. At the time, there was a lot of mismatch between the developmental screenings. Clinics were kind of waiting to get the kids in for their screening and then subsequently missing their second birthday. So we worked quite a bit on that. One major caveat here is that our CCO is very small. We have probably a couple hundred kids who are 0 to 2. That's much harder to do this kind of thing for a larger CCO that has 10 times as many kids. But it did prove very fruitful. So next slide, I'll show you what we found. So this is 2017 data that we presented in 2018. What we found at the time, and this was somewhat based on assumptions, was that just over 9% of the misses were due to complete refusal. So if there was nothing in alert, that to me said that they just weren't having any immunizations at all. We could also tell a little bit what delayed schedules were just by looking at that data. Again, just eyeballing it, so assumptions there, that was less than 1%. But one of the major opportunities that we found at the time was that there were late or incomplete immunizations, and the majority of those were the 4th Dtap, since that is a series vaccine. So did a lot of improvement there. Next slide, please. And you can see that paid off. So this is our status over 2018 and 2019. And we had, at the time, the highest rates in the state in our CCO, so a little bit over 88%, and felt pretty good about that because it seemed that we had hardwired all of this approach, and everybody was doing really well with that, and by far the most of our kids were getting immunized. Next slide. Then we know what happened there. Here comes 2020. Next slide. And what we've observed is there really was the disintegration of hardwiring over the past couple of years. There's been a tremendous amount of frontline staff turnover. The frontline staff, they're kind of the linchpin in all of this. They're the ones calling the parents to bring their young children in. So oftentimes they're not even clear on who they're calling and why. I mean, they know they have this appointment, but it just wasn't quite the same. Staff and providers, those of you in clinics know, you're pulled in many different directions. There's been a lot of focus on COVID, obviously, and so some of these gap lists and things have taken a back seat. And then also provider burnout, I think, is a big thing as well. You can't talk about all the things in all the appointments, so that's been challenging. And then a couple of you, Steve and Susan, have pointed out there's vaccine hesitancy. Parents just aren't bringing young children in because they, to this point, have not been able to be vaccinated. And also to Susan's point earlier with regard to vaccine hesitancy, there's a lot of what's called do your own research, DYOR. It's a thing. There's been a couple of New York Times articles recently on that where parents are doing their own research. And as we know from the ladder of inference, they're finding information that feeds into their own belief that the vaccines are not a good thing. So we're combating that as well. Next slide. So what are we trying to do about this? Next slide, please. We're having pretty detailed conversations with our health council board. Our health council board isn't really an in the weeds kind of a crew. So that's been, I think, pretty helpful to get them back on track. Clinical advisory panel as well, discussions about what to do there and taking their suggestions. We're working on a training for frontline staff about why this work is important. So just in the development of that training now, but we'll start with some member stories and also have kind of what I'm calling a motivational interviewing light kind of approach, working with staff to really create their own script. I always bristle at the word script because it's not as genuine, but I think if we work with staff to try to help them understand why they're making these calls and why it's so important, they can begin to create their own language back to the MI light so they feel a little bit more comfortable making these calls, and they're not trying to convince people to come in, but really trying to connect with the provider and encouraging them, and then the providers can have those conversations, and of course including lunch in those, because everybody likes to eat and have a meal. The other thing that we're doing is handwriting out thank you cards for frontline staff. Again, very tedious. I know that sounds really quaint, but there was recently an article in The Economist, the May 26th edition, about the power of small gestures. And so, you know, I'll try anything at least once. And so it might seem like a small thing, but if it's helpful and if, again, helps one child from getting really sick or dying, I think that's worthwhile. And then lastly, we're engaging our primary care provider clinic leadership in the performance as well. And then really just trying to support, again, those linchpin frontline staff who do a lot of the work. And as I've said, meaning doesn't pay the bills, but it sure makes the day seem a lot better. So hoping that that's helpful there. And that is what we're doing. So I'll open it up to any questions or comments anyone has. Trying to get us caught back up on time.
Okay, that was great. Thank you. Do we have any comments from the group? I'm looking for hands out there. I don't see any right now. And let me just check. Yeah, we are very much right on schedule. Thank you. And then I think next we have Jay Rosenblum. Good, perfect.
Well, hello there, everybody. First of all, I'd like to reiterate what both Susan and Elke said, that and I'm going to send Lisa the link to that New York Times Magazine article. And anybody who hasn't read that really should. It does take an hour to listen to, but it's well worth the time. So let me send that link. And it goes into so much more detail about a multitude of the things that we're facing. It talks a little bit about the history, the Dr. Wakefield. It talks about, Jenny McCarthy and Robert Kennedy Jr. and all that stuff. But it also talks about what people have been seeing, the politicization, because it's not just COVID, and it's what we're all facing. So I'm going to have you next slide, and then I have no ties to the pharmaceutical industry. I always like to start with that. Next slide, and you can skip the next one too. Oh, no, not that one. Keep that one. So in 2008, so 14 years ago at the CHA, and so let me take a step back. The CHA is a collaborative of primary care, private practice pediatricians, mostly in the Portland metro area, but it goes from Vancouver down to Salem. So we have, I lose track. We're up at like 140 pediatricians across 30 practice sites. So what in theory we should be competitors with one another, but we all come together. It's kind of like an IPA. It's so the Alliance, really where we focus our efforts is quality improvement. We can look at data for, I don't even remember, it's 170,000 kids. And so starting in 2008, the question of how are we doing with vaccines and what are the barriers? Because we can assume that the problem is, parental resistance. We can assume that it is that Tucker Carlson's the problem, but really we need the data to know that. So since 2008, every month we've had every one of our practices poll who are the 2-year-olds that showed up as not up to date on alert, figure out which of those kids were actually up to date, but alert didn't have up to date data. And then what were the reasons? And then 8 years ago, we started collecting data on teen vaccines as well. So next slide. So this is 2020, 2021. This is our 2-year-old immunization rates. And this is for combo 7 and combo 10. So a little bit higher bar than combo 2, combo 3. So it's not apples to apples, but you can see that our up-to-date rates with these vaccines, combo 7 doesn't include the flu, combo 10 includes the flu. So if you look at the combo 7, we're at 72%. With our goal is 80%. If we look at combo 2, we're above 80%, but it shows that that we still have a lot of room for improvement. Next slide, please. So what we do every quarter is we break out practice by practice, and I have it grayed out the names of the practices, but down at the bottom, the total, you can see this represents 7,800 kids who had turned 2 and who were or were not up to date with the combo 7 and combo 10. And so a wide variability. Some practices are in the 80s and some are in the 50s. But what this does is this puts a little bit of pressure on individual clinics. When you get a report like this, we all want to be top performers. And so when you see that you're not doing well, you can get a list like this and reach out to one of the other practices in the Alliance and say, hey, what are you doing? And it also allows us, we've had times where a practice that was performing well, all of a sudden stops performing well. It was an internal problem that they weren't even aware of, that they had, their lead MA had left, somebody new had come in, and that it was months before they realized that they were missing opportunities. Next slide. So if you look for this is just a quarter, this is July through September of 2021. The reasons 2-year-olds weren't up to date, 45% of them, it was because they had missed a checkup. 4%, it was because there was a missed opportunity. They were in the office, we just didn't give them the right shots. 26%, it was rotavirus was what was keeping them behind. And that's one where if the kids miss their 6-month-old checkup, they come in at 9 months, we're never going to catch that back up. And so we like to pull that out just because that's, yes, we want to get all the kids in for every visit, but that's not one that can be made up. But the blue bars show you the parents who refused vaccines, refused all of them, refused some of them, or they're on a delayed schedule. Well, when I look at this and I see that 45% of our kids who aren't up to date is not because of the parents refusing, it's because we didn't get them in. That's something that we can address. So next slide, please. And then this is just it puts it in a number. Some people like bars better, some people like tables better. But so 74% of the kids who weren't up to date, it was a process reason, and 26% are parent reasons. Now, that's not to say that there aren't sometimes that we keep calling parents and say, get your kid in, and they still don't come. So that's still a missed checkup. So some of those are the parents, but some of that is what we have control over. Next slide. And I know that the focus here is on the child immunizations, but because we're doing the same kind of thing with adolescents, this is the data on our, which of the kids had Tdap and a meningococcal, and which also had their HPV. And very interestingly, it's almost the same number of kids in the 2-year-old age bracket as we have in the 13-year. And we're also looking at this. So next slide. And yes, this is all payers. This is not specific to Medicaid. The reasons adolescents were behind, it was 67% of them were because because they didn't have a visit. Next slide. Again, so here 67% it's process and 33% it's parental reasons. Next slide. So what have we done about it? We are mostly working on working our list of kids who are behind. I don't feel like I have one family at a time. I can try to address the politically motivated vaccine hesitancy, but I have found that kind of like, from the beginning, way back 20 years ago when we had families who said, I'm not going to get any vaccines, it was a very low likelihood that I was going to convince them to get all their vaccines. I might be able to get them to get a couple. But there was a point at which you knew that you weren't going to make any progress. For those people whose primary source of information on this is particular news networks and websites, I know that, and it's a growing number of patients, but I know that I'm not going to be able to overcome that with any infographic from the CDC, the WHO, the AAP. Those are not trusted sources to these families. And even when I talk about, what is the scientific method and what is the risk of having myocarditis from a COVID vaccine versus the risk of myocarditis from getting COVID, or encephalitis from the MMR versus the encephalitis from measles. We're talking about, a 1,000-fold difference in their risk. I just find I don't get anywhere. So I'm putting most of my effort into doing reminder recalls. We actually hired a staff member to do nothing but work these lists, to call and send letters and try to get the families in. One of the things that hasn't been addressed today is that we can't hire enough staff. And I think that that's starting to contribute to some of our declining catch-ups. I don't even know how many MAs short we are right now. And we're doing weekend COVID vaccine clinics. We're doing, we're working the staff that we have, but I need extra staff to be able to get more calls made and more patients scheduled. And so that's not something I can do anything about, but we call our the person who's doing all this working list, she's our patient panel coordinator, and all she does is reminder recalls, and it's helped. We measure the number of appointments that this individual is able to make, and it's a significant improvement over when we were just kind of doing our same old send a postcard once a year or send an extra postcard saying they're behind. We didn't get good response to that. But if we nag them enough, we can usually get them on the schedule. Now, a lot of times they don't show up for their appointments, and then we're back to square one and having to do a lot of phone calls again. Any questions about that?
I'm looking, I don't see any hands right now. Dr. Rosenblum, thank you so much. Very helpful. Yeah, go ahead, Lisa.
I'm going to ask a question. Have you found whether it's the phone call, or do you use different things like texting, reminders, or any of one of those that are more effective than others, or do you do all? Phone, texting, everything?
All of the above.
All of the above. Do it all.
We do phone calls, we do texting, we do emails, and we do snail mail if we have to. But I think that the snail mail, I think, has the lowest return. Okay. I think those all go into everybody's recycling. It's really if we can get them on their phone, whether it's a call, a text, that they're right there, and we know that that's where their calendar is. And we've had much better luck. We just this week switched to a new EMR that allows us to text more easily. And so we're able to do a little bit better job now on that.
With the text feature?
Yeah.
Okay. Have you done any different incentive type things or in the past?
Not specifically for vaccines. You know, the CCOs do have incentives for the well checks. And if they come in, I mean, really bottom line is, if you want to measure any one thing for the quality of what we're doing, just measure our well check rate. Because once they're there, that's where everything else will follow. Our screeners are going to go with that. Our vaccination rates are going to go with that.
Yes.
So if we just get them in. But we don't really have the funding to do any kind of incentive specifically for vaccines. And maybe that, you know, that maybe the CCOs, instead of doing an incentive for just one vaccination, maybe they could have, you know, because that's for the teens that they usually do that. You know, maybe there could be a bigger incentive for anybody whose child got all their vaccines by age 2. You get a bigger, then that means that they probably would have had 5 visits by 15 months, which is a metric. They would have had all their vaccines. They would have had their 1 and 2 year developmental screens. But that funding we don't have as an individual clinic.
Yeah. Thank you, Jay. Any other questions or thoughts? Jennifer, would you mind going one slide? I think he has. And this is just straight QI in general, which I do appreciate you putting forward, Dr. Rosenblum, which is great. Plan, do, study, act, repeat over and over. Do you want to speak to it?
Yes, I want to speak to it because there's always fires to be putting out. And what my particular group, and in my group, we have 12 pediatricians at 3 sites. What we got really good at doing is we'd sit around the table and say, oh, here's a problem. We make a plan, we implement it. We would do plan, do, plan, do, plan, do, plan, do, plan, do. You know, that taking the time to go back and study and change, it's really hard. It's really hard to do that, but that's where the improvements come. I mean, we kept saying, oh yeah, 6 months ago, we implemented this program. How's it doing? And so you really have to do the plan, do, study, act. You have to stay on top of that, because the question of, you know, how well is our new texting going to work? How many of those were converted to appointments? How many of those appointments did the patients keep? We need to know that, because otherwise we need to change what our plan is. And I don't think my practice is alone in identifying problems, implementing solutions, and then moving on to the next fire.
I appreciate that. That's a very good sentiment. Sometimes people skip just to the do too, and I think sometimes they skip the plan and they go straight to the do, and then maybe skip over the study and go do, act, and then come back to the plan. So there's a plan, a do, a study, and act, and hopefully what you've heard is the repeat over and over the plan, the do, the study, and the act, which I appreciate.
Lisa, this is Jeannie, and I totally appreciate that as well. I think the one thing that we have to remember in our plan, do, study, act cycles are the part where we get the community involvement into that. So I hear the outreach and the ideas, and I think it's wonderful. I think one aspect that I feel like we're still missing is, what does the community say about the best way for us to reach out to them? Like, what does the community say is the best way to reach them where they are? And where does that where is that in the plan, do, study, act cycle? And where is the community feedback when we're looking at the study part? And I think, Jay, you probably have that in there, but I'm thinking that maybe as we look at this plan, do, study, act, we need to remind ourselves or put it in there somewhere a little bit more openly, like, and by the way, if you're really looking at ending health inequities and disparities, it has to include community feedback as part of the study part and the planning part.
Correct. And it can be easy. I mean, it can be as complex as you build it, and it can be as easy as talking to your patients. And you can have structures of community health counselors. Elke mentioned going out through their structures in their community. You can have the structures, the governance structures, and you can also, well, what I did was I actually just asked, I went through my community health council, but I actually just asked the patients in my lobby. I just sat up there and talked to them. I mean, it was, you know, it wasn't an either or, it was an and statement. I talked to the council and I asked them in the room. So it worked both ways. Jay, did you want to say something?
We do have parent representatives on our quality committee, because you know, and it's hard because you can, you know, one person's opinion is one person's opinion. Sometimes it's really insightful, and sometimes, you know, that what, you know, everybody wants something a little different, but it has been a really important voice in our assessment and planning, is having parent. And what we do is we have applications, we do vetting, and then we pay them. It's not a lot. I think they get something like $100 a month for attending 2 meetings, but we have parent representation whenever we're going to make any changes within the practice, which is some help.
That's great, Jay. I'd like to again thank all of the panelists that have given their time, one, obviously preparing the materials, but also coming today and listening and providing their expertise. I have put in the actual chat string, and you maybe even have it in one of the last slides, but a Survey Monkey. Thank you again to Laura Krieger in our Transformation Center, who helps corral all of this information together for the Learning Collaborative. We are thinking through actively what the next Learning Collaborative will be. It most likely will be late summer, early fall. So please do fill out the Survey Monkey. It really helps us in the and the chairs in thinking through what the next topic will be. Appreciate all your time. We will convene at 1 o'clock for the quality performance improvement session. Everyone will have hopefully a lovely lunch, can stretch out, maybe get some fresh air. And we will see you all in the afternoon session for the quality session. Thank you very much. Have a good lunch break.
Thanks, everybody.
QPI session, quality performance improvement session. I don't think we can roll any more acronyms into one meeting. I'm Lisa Bowie, the Quality Improvement Director. I am wearing black glasses, big old red lipstick for today, apparently. Our co-chair, Laura Matola, is on the line. Hi, Laura. She does not have a camera for today, but she is here.
Hello. Well,
let's see here. Oh, let me keep admitting people. Hang on. Let's see. Jennifer, are you back? Let's go ahead and see if we can advance a slide, please, Jennifer. Thank you. Just as a reminder, please remain muted when not speaking, and when possible, you can use the raise hand function, which is under the reactions button on the bottom of your Zoom buttons. And when you do speak, if you can remember to try and turn on your camera and state your name and organization you're from. Before we get into the SUD statewide PIP, I'll go ahead and go over a few announcements. For those that are on the line, let's see here, last Thursday evening, I think I did, late last Thursday, I would have sent the CCOs your TQS 2022 written assessments. Those would have gone out to the CCO contract administrators as well as the current CCO TQS leads that we had on file. So your actual written assessments have been delivered, as well as the contract deliverables acceptance letter documentation. So both of those documents should be in the hands of each individualized CCO. In that letter, it also talks about kind of the timeline for when documents will be posted. So you want to pay a particular attention to that timeline as well. It also talks about if you haven't done so and you'd like to schedule a voluntary phone call with OHA as far as the TQS leads or any specific subject matter expert, then you can do so as well. Those voluntary calls are being scheduled sometime in June or July. We have several different holds on our calendars. So obviously, the sooner you schedule them, the more opportunity or more options you might have as far as what is available. Are there any questions about the CCO TQS written assessments that were delivered out by email? Okay, let's see here, we're in June. The next, the end of July will be your next quarterly reports. You will want to submit that for all of your hits, so that will be due to the CCO MCO deliverable email box. So that will be, again, July 31st. Those will be coming to me. So if there's any questions about that, please send me an email. What else is there? I don't think there's anything. Oh, I will be talking at some point. I'll probably send you all an email. I'm thinking, and maybe we'll ask here soon, we'll do a kind of a TQS peer learning, kind of what we did last year. I think that worked out pretty well. I'll talk to Laura, your chair, Laura Matola here at All Care, about that TQS peer learning. So you'll probably hear something from Laura Krieger. Yes, there's lots of Laura Krieger at the OHA Transformation Center, where we'll ask you all as TQS leads in the CCOs, which project of one of your TQS that you'd like to share. What we usually did was we basically, as you go through your CCO TQS written assessments, then what we're going to do is we're going to do a peer learning. And that peer learning will be done at the QPI session, whether it's going to be in July or whether it will be August, I'm not sure. We'll talk to Laura Matola, your chair. What we'll then do is we'll email you all, the TQS leads, and we'll say which project of your TQS project do you want to highlight. You all then will submit to us which project it is that you want to bring to July or August QHOC, and then we'll create kind of like affinity groups, and then we'll kind of make breakout rooms that you can kind of pop in and out of to talk about those particular projects, kind of in a peer learning session. So I'll work with Laura Matola, our chair, to figure out whether it's July or August that we'll do that. And then Laura Krieger or myself will submit an email out to you all as TQS leads to start to field those project inquiries. And then we'll create those affinity groups. And then we'll let you all know and publicize that through the innovator agents, through your CACs, et cetera, to kind of do that peer learning for the TQS areas. Any questions about the peer learning of TQS? And then subsequently, we will, as always, do the TQS lessons learned and opportunities for prepping for the next TQS. So this is that continuous improvement around transformation and quality. And we'll do that in the fall in preparation. So you all have your written assessments for 2022. You'll digest that. We'll do peer learning first, and then we'll do the global themes webinar. And then we'll start to do the subject matter expert webinars for the components for preparation of next year's semester. Okay, that's the whole TQS update. And we'll put some of that kind of in print in actual update slides in July. I don't have any other updates, any other general questions or anything else before we get into today's two topics, which is SUD design, statewide PIP, as well as National Diabetes Prevention Program technical assistance. Okay, let's go to the next slide, which is just a topic slide. Okay, so I will do a update of where we stand with the SUD statewide PIP design discussion, and then just kind of open it up for discussion. So since we last met at the May QHOC, and I again missed the May QHOC, but we have had a couple of meetings since then. So the CCOs and I have met once since the May QHOC, and then we've met internally with the OHA subject matter expert groups, and then I've also met with some leadership within the SUD waiver team in regards to the statewide PIP, and then I've also met with some other leadership within the OHA on the SUD discussion topic. So what I appreciate is when we had the conversation with the CCOs, we elevated the conversation around residential treatment. So what I had heard from the survey results in April, as far as topics and population from internal and external, was residential treatment. I also heard IET, initiation, engagement, and treatment. We obviously did not need to discuss initiation, engagement, and treatment very much from a population and from a metric side because it's very well established. So you all talked about residential treatment internally and externally a little bit in May. So when I talked with the CCOs externally, not at QHOC, the meeting, I think it was the end of May, we talked about measurement and what would be some potential measurement, talking about capacity and access. And we talked about whether it was timely access, whether it was capacity. We talked about beds. We talked about a whole host of things. We talked about why timely access of residential treatment is not necessarily a viable method for measurement in this arena because there's no index date. There's no measurable way to measure index date of an individual who needs residential treatment, either from diagnostic or from procedural. So that's kind of the summary of where we landed there. We also heard the concerns from CCO in regards to the need to move into workforce and the there. How can we still work in the workforce arena? And I again reiterated that we can't measure workforce in a way that is and basically it can't be done in a way that is allowed from a validation point of view for CMS protocol for external quality review at the CCO level. So the answer is no. From the beginning of the SUD PIP, or in the beginning of any statewide PIP, the decision as to whether we follow the CMS protocol is question and answer. And the answer was for this one, yes, we're still going to follow CMS protocol. And if we follow CMS protocol and if it goes through external quality review validation, which means by CCO, you have to be validated, then workforce data is not a viable option for CCO external quality review validation. So therefore, workforce data, unfortunately, cannot be used for a performance improvement project at the CCO level. So hence, no workforce. Does not mean we can't do workforce. Doesn't mean that you can't do it for like one of your other performance improvement projects at a non-statewide level, which is what I said at the last CCO non-QHOC meeting. So we revisited the workforce conversation, again, excluded it from a statewide because we follow the CMS protocol. We also discussed all the loveliness about beds and the practices of residential facilities and all of that. So we didn't necessarily land on viable measures, so that was a conversation that we carried forward today. That's about a summary where we landed from the external meeting, and all that were at that meeting can easily chime in. Where we were internally, as far as residential facility, I had talked and gave that feedback. One of the conversations that I'd like to talk about also today, internal didn't have any grand ideas on measurement of residential treatment. So I gave the feedback of the external meeting. Internal didn't have any magic measurement yet. One of the other conversations I'd like to go in the space with you all today. So residential treatment, anyone have any lovely ideas around the scope of measurement for residential treatment to improve access? And again, we're not talking about timely access because I've excluded that. But if we're to go into initiation, engagement, and treatment, we already know there's an established measure. One of the questions I wanted to pose to you all as CCOs is, where in the initiation, engagement, treatment work that you have been doing for this measure, since it has been a selected CCO incentive measure, where have you been working in this space, and where do you think you'd be going in this space that's aligned with OHA's strategic goal of eliminating health inequities by 2030? So we haven't necessarily had that conversation. Obviously, we don't have to have the measurement conversation for IET because it's an established measure, but I'm curious from the CCO's perspective, how the initiation, engagement, and treatment measure and the work that you all have been doing and plan to do lines that particular body of work up to OHA's strategic goal of eliminating health inequities by 2030. So this is where today's conversation for SUD statewide PIP is going. IET, health equity, health disparities 2030, and the parallel track of measurement population is adult/child for residential treatment. That's the floor. Anybody? Cassie wrote, there's an established measure for ED visits and reducing access of ED as part of SUD goals. Thank you, Cassie. So I'm going to go ahead and open up the floor. That's kind of the two-pronged conversations I'd like to go for today. Who wants to jump on in to the deep end?
Cassandra from Pacific Source. So I do like that we're moving away from the direction of residential treatment, because it is really hard to validate their measurement, and also it's just really difficult for our CCOs to make progress in that area. So I do really appreciate OHA looking at other topics such as the IET measure, and possibly I'd be really great if we could also look at other waiver goals that would have a connected, maybe validated claims measure for this. So I just wanted to really say, for start, I'm glad that we're kind of looking at other topic areas.
Yeah, I'm basically pursuing both parallel tracks, Cassie. So, but yes, I haven't talked about IET as a population or measure because it's already established. But I do want to hear about IET from a how and what CCOs would be doing and approaching from the alignment to the health disparities and strategic goal of 2030 for OHA. And because we haven't had that conversation, because might as well now, because we don't need to have the conversation about measurement because we already have it. And then I'm still looking at the parallel track of measurement because I'm still talking to our SUD team, and they're actually on now. I think I saw Dana Pearson join, and we'll have to call it here soon. But I'm still looking at both, looking at the data on both, talking to both CCOs and internal staff, and then presenting both options to those powers within OHA to say which one best aligns to where our system is at, where our CCOs, and what lines up with the goals of the waiver. So you can chime in on either one of those options and let me know your thoughts on either.
I would say, like, I think it might be helpful to think about this from when we talk about the health equity lens, since we are trying to, you know, make both statewide PIPs have a health equity focus. I feel like internally we have had some discussions at Pacific Source around Medicaid assisted treatment and how we could have a justice focus for the health equity part of this PIP. I'm not sure how that would align with the IET metric, but I think that's one thing that would be good to kind of put on the discussion board for this topic.
Lisa, this is Graham. Can you hear me?
Yes, Graham.
So I guess I would ask a question back to you. So you're asking how would selection of the initiation and engagement of treatment measure align with OHA's equity goals? And I guess I would ask, what does it take for something to align with those equity goals from your point of view? I mean, are you trying to figure out how a PIP around IET could be meaningfully construed to be addressing health equity? And is that specifically racial equity from the point of view of OHA?
What I'm asking is one of the conversations that we had early on, I think it was like, honestly, possibly one of the early March, early April, when we were talking about this topic. Someone threw out IET as a potential topic, right? That was before we even did the survey. And someone said, well, Lisa, you know, we're working on IET now. And I said, yeah, pretty much knew that. But we could do so much more if we're doing it as a statewide PIP. You know, someone pretty much put that forward. And I was like, well, what's that so much more? If we focused on it as a statewide PIP altogether, we could do more. And I was like, well, what's that more? That's what I'm asking. And is that more in that we would be, the CCOs would be collectively working together? Is that more in that we would be partnering with OHA, obviously? Is that more in that we would be looking richer in our data and trying to, you know, for us, that would mean we would be looking and trying to reduce the disparities. We would be we'd be creating different systems. You know, I don't know what that more meant when this individual is putting that forth, right? So when you're looking at certain CCO incentive measures, sometimes you're not creating the system, you're just, I don't know, saying, you know, putting it bluntly, going for the low-hanging fruit, right? And so is that, I wouldn't trying to get in this person's head, but where they're trying to say, if we were to do this statewide PIP, we could create these systems of quality improvement versus going for the low-hanging fruit. I don't know what the person was putting forth when they, were trying to advocate for picking the initiation, engagement, and treatment topic as a statewide PIP. So I'm asking the CCOs now, you all CCOs, if in fact IET is something you want as a measure or as a topic area for potential inclusion as a statewide PIP. Because the other thing is, then what is it that more is? Because you'd all be working on it together. You're already all working on it individually now because it's an incentive measure. But what is it that more is? And then also, how does that align to the agency? Well, you all supposed to be working in equity work. Have you thought how you're going to do that, or are you doing that differently now? And if not, is this an opportunity to do that?
Okay, I don't know. Maybe you're reflecting to something that I said in March, and you're trying to get into my head. I'm not sure.
No, it wasn't you.
Okay, I guess for me, as I listen to you thinking about this, part of this is just that the more we can align efforts, the more resources go into like a single improvement problem, the better off we're going to do from a resource point of view. That's just like my 10,000 foot perspective on this. And so I can't say tangibly what that means. I know that for HealthShare, that means that more conversations are about the same topic. It means that we can more easily tie in, once something is an incentive measure and a PIP, and we're approaching it with, more analytics, then the opportunities for improvement or investment are just increased. And I say that because the opposite is definitely true. If we have 1,000 things that we're working on, then you're spreading out 1,000 investment opportunities. So, from my point of view, I guess part of it is just that the more these things can be aligned, then the more we're talking and sort of deeply unpacking certain problems. And this one, it's a particular sort of engagement mechanism, right? Both the initiation and the engagement part are part of the same sort of path or workflow that somebody would follow. And I do think that there's opportunities for us to work on this more collaboratively across CCOs and with OHA. And I feel like every time we talk about this, we sort of dismiss the data sharing problems of it, or we blame it on 42 CFR. And I think that that's totally true, but that's a huge limiting factor in doing any of this work effectively. And so having a statewide PIP where that is one of the drivers of a lack of improvement, and that's explicit and sort of called out as like this, this was important enough work for us to choose it as all CCOs aligning around one area of improvement, and we can highlight this really significant barrier. We'll continue to sort of bang the drum for trying to address that in some meaningful way. I think there's all sorts of tie-ins on this measure around health information technology, information exchange, all sorts of things there. And this is a nice proxy for that. In terms of the equity piece, I'm looking at some of our data now. I see some issues around language or some variants around language, some variants around race and ethnicity. Not enough for me to like highlight specifically what they are right now, or whether they're sizable enough numbers for us to know for sure. But I think that us focusing on that as CCOs on this one measure would allow us to spend more time looking at those disparities. If anything, often I think that we're seeing disparities in both diagnosis and sort of early preventive engagement among certain populations when it comes to substance use and mental health treatment in general. And so just sort of overall utilization rates are lower among some groups than others, which is something, from a preventive point of view to be taking into account. So I think there's plenty there, and I can understand why the conversation has pushed toward trying to align around this really pretty sticky measure. I can't say concretely you'll get more of X, Y, or Z if we align around it. Maybe others have better ideas about that.
Thanks, Graham. Is the sentiment really from the CCOs kind of to Graham's point of really around resourcing? I'm just going to be pretty blunt.
Well, I would say, this is Cassandra again from Pacific Source. I mean, I think part of it is resourcing. I also feel like I think it does kind of, when we're allowed to align with other existing measures, even if it's an exact alignment, it does help us to kind of implement things a bit quicker too, aside from having a focus area that is maybe not in alignment with one of the quality and centric measures or otherwise. It just takes much longer to implement and to kind of get things running. So with this starting in January of 2023, and us still kind of trying to define the topic and the measure this summer, it is difficult to kind of know how to begin to implement. We don't quite have those pieces put together yet.
Because if we think from a quality of care, let's just, none of this is true, so don't freak out, all CCOs on this. So let's hypothetically say expert went away. Let's say the IET measure went away as an incentive measure. Like those just are all gone, right? Now we're just going to go all physical health, and those are the only incentive measures that exist. I mean, that's not obviously happening, but then all your resources from, I'm just again all hypothetical, 100% hypothetical. Then from a resource standpoint, then the CCOs are like, you're going to all drive towards, physical health and oral health, because now all you're going to do is, all incentive measures just went all straight up to oral health now. Just, again, making it all up. Then the resource conversation would be, you're going to divert to oral health. Again, 100% made up. The statewide PIP is not going to follow that track, right? So I'm not going to, go with the curves of an incentive program, or that's not the way we've done it. Understanding where, and this is SUD PIP, not even the integration. The SUD waiver very clearly has goals, but I also understand where the system is at in a pandemic world. And I obviously came from a provider, so I still, have that conversation in my head where I'd be yelling at myself at the state, like, you want me to do what? Or I'd be yelling at Graham, you want me to do what? Because I'd be trying to get people into care. I'd be actively trying to get people just to answer the phone because they don't want to come outside their doors, right? So I get that, but we have to think from a quality of care point of view, what this SUD PIP is trying to do. And from a care coordination point of view, we've got a whole host of problems, and we all know we rank the worst in behavioral health. That's like in the news. Nobody needs to, we have data to back that up, but it's also in the news. So we can focus on residential treatment, which is one area that the survey said and internal has said. So that's one area that we're clearly following that track. We also know initiation, engagement, and treatment measure does have some very strong care coordination and quality of care components as well, which is why we're even entertaining this conversation. But hypothetically, if the initiation, engagement, and treatment measure were to fall off the face of the earth as a incentive measure, and expert were to fall off the face of the earth, which is somewhat a precursor to the IET, then would you all CCOs be still saying, please do IET? These are those conversations that I don't know what the answer is, but I have you all telling me IET and I have residential treatment. Both are very valid from a data perspective as far as background. We have more than enough opportunities. We both of them have areas that we can grow in. But I keep hearing IET from CCOs, and I'm trying to find out if it were to fall off the face of the earth, is it still, I know from a quality of care perspective, it's still important. Do you have a plan of how you want to engage in that space because of the quality of care perspective, or is it because of resource perspective? I can't answer that. Only you guys can tell me that.
So Lisa, can you hear me?
Uh-huh.
Perfect. So if I'm wondering, because I was not on the May call, what was the discussion around the residential treatment to improve access, if we're not talking timeliness to access?
The discussion really centered around, so timeliness, because you can't do an index date. So then it became the conversation, and we're just going oh so candid. Apparently residential treatment, some of the issues with residential treatment is around the facility. So I'm going to say the facility itself, and how one gives out beds, and how you, I don't know, basically hand out the beds. You can't, and the payers in which they give out the beds to. And that conversation was really about, if we're trying to look at increasing the capacity around the beds for Medicaid, the conversation is centered around interventions, which obviously we're not talking about interventions, right? Because we tried to skip over that, and we tried to talk about capacity. We talked about capacity of the residential facility. So apparently there's capacity, but it's not capacity for Medicaid. It's capacity as a whole. But there's this thing that you can't have, which is apparently a wait list, because that's a no-no. But apparently there's this false narrative of a wait list. And the system of residential treatment has varying different ways of reducing capacity for Medicaid. So there's no method currently to measure the limited capacity for Medicaid clients by CCO from a measurement perspective. So then we have to look at it from a member perspective versus a facility perspective. So now I have people in the agency thinking about how to measure capacity at the CCO level, not at the facility level, because we don't count beds by facility. We can't count facility beds by payer, by CCO. And there ain't no wait list. That's just a summary I could give Laura.
Lisa, this is
so
Jeffrey.
With that, I would go ahead, Jeffrey.
I'm sorry,
Did I
Laura.
get any of that wrong, Jeffrey?
No, not at all. I just was trying to brainstorm a way around things, because the non-wait list is a bit of a kind of a fly in the honey. So I wondered if we could measure. I wondered if we could measure instead referrals by CCO to particular residential facilities. So those who are meeting criteria for residential, who have been referred. Since we can't measure a wait list, is there a way that we can measure a number of referrals? Because I think that's the frustrating part on our end in care coordination and behavioral health care coordination, is just this sort of like, we know that there are a number of people being referred, but they can't accumulate on the wait list that we can actually see and measure. And then we also have this sort of, and I hate to say this, but I'm sure that I'm not the only one who's been privy to this. We have sort of well, the wait list for residential is so long. Why don't you could participate in intensive outpatient services, and there's a lot available with outpatient right now. Let's see if we can get you started with that, and then we'll address residential down the way, even though somebody does technically qualify for a residential bed. So anyway, it was just a thought that I had that just kind of popped into my head about sort of quantifying referrals as opposed to waitlisting. Thanks.
Exactly, Jeffrey, because that's when we're trying to flip it and looking at the member, right? Because that's a referral is by the member versus a facility, to get away from the bed issue. But trying to still capture those that need to get into a bed, basically.
Right.
Because that's what we're trying to improve, is the in location, which is the residential facility. But you know, and the interventions to get there are a whole host of different things, contractual and, you know, incentives and value-based payments and all those other fun things that people want to leap to. But it's really what we're trying to impact is the tracking of increasing the number of beds, however you get there. But tracking it by number of referrals, tracking it by, I mean, technically IET somewhat gets you there too. Laura, did you have another question about that whole bed issue, which is why we can't track it by facility? Because there also isn't a standard wait list, and there also isn't Medicaid numbers at the state or CCO level.
No, I think Jeffrey captured what I was kind of thinking a little bit. And just then going back to the original question about, do we want to do IET for resources because of the resource versus, right? I was just trying to get the perspective of, okay, where's people actually coming from? Because we know what IET already involves. And so trying to think about what would the residential treatment bed would involve, you know, both of them sound like very needy PIPs and work to be done. It's just, so that's where I was just coming from. I was just trying to wrap my brain around both aspects and trying to figure out, okay, if I had to pick one, which one would it be and why?
Yeah, and at the last CCO meeting where we had learned, or where this whole bed conversation happened some more, it was stated that it was very, very much said again, but it was about the resource, about the IT. The system is overburdened. That wasn't the words that were used, but that's me summarizing. And can we align and do IET? And so then I just circled back to one of the earlier conversations. If we do IET, are we doing it because of resource? We're doing it for the quality. And if we're doing it for the quality, what are we doing? And again, I'm just going back to my memory of someone saying, well, if we do it for the statewide PIP, we said we could do so much more. I'm like, what's that more? I'm not trying to be argumentative. I'm just asking, what would you need from me to help you do more? That's also what I want to know. Like, what do you need from me to bring, you know, the Danas and the Johns and everyone together to help you do more? Or like Graham just called out some things like HIE and HIT, and no, I'm not going to go to the Attorney General's office for 42 CFR, but there's other things I may be able to do. So what do you need from me to help you do more with the IET if we happen to choose IET? That's what I'm also trying to get at, not just to be argumentative, because, you know, I don't like to always be argumentative.
Lisa?
Because then I can do more, help you do more.
Can I ask, this is Graham again, can I ask a question from a different perspective? So I'm hearing interest maybe from OHA in looking at residential.
Mm-hmm.
Are there explicit things that CCOs should be doing that we're not doing that would be part of an early playlist that would benefit us aligning around a PIP? So let's say OHA, we was to say it will be residential, increasing number of residential beds. Is there like a punch list of things that CCOs currently are being asked to do to increase residential beds that we aren't doing? And I'm not asking that rhetorically or, you know, argumentatively. I'm curious if there's a similar, you know, is there fruit, low hanging, high hanging, that people are looking at and saying that the group of folks on this call if better aligned, could address that would start moving that dial, whether it's wait times, number of beds, et cetera. And I mean, if so, that's worth talking about, I think. I'm not finding a lot of maybe utility around the resourcing question, like why we would align around IET because of resources. I think I can't think of a single decision that I make during my day about things that we should work on that don't take into account what are we already doing, what are the other competing, things that we're trying to use our time on. I mean, it's always about resourcing. All things being equal, we would address all the things that relate to quality of care. So I think it's, it does come down to sort of where are we already focused and what are we focused on. But you're asking like, what would change if we addressed IET? I guess I would ask what would change if we addressed residential from the agency's point of view, and how does an aligned PIP help strengthen that lever? And maybe there's a really great answer, or maybe, I need colleagues from HealthShare to actually inform me some more, but I'm curious if you have things that immediately come to mind.
Well, since I'm not a behavioral health SUD SME, the answer is I don't have the punch list, but I'm pretty sure I could probably get you one. But I'll ask some folks. And I think, the other thing is like when we did the opioid PIP, the other thing is I know, we and unlike the mental health access is because, I was assigned to opioid or not opioid COVID work. We will for the SUD one, and I've already talked to the SUD team. They're gonna create similar to the opioid one, which I still have to do, but right now we all know the behavioral health team is kind of a little bit busy right now with the 110 work. I know the SUD team is planning on creating an internal team to support the CCOs with this SUD PIP. So very similar, so like we did with the opioid statewide PIP, the high dose opioid PIP, there will be an SUD team to support you all, whether it's the IET or the residential treatment. So FYI, that will happen. I already talked to a couple of the SUD managers on that. So that punch list or whatever it be, whether it's IET or this SUD residential, there will be that. And that's why I'm also trying to figure out what it is resource-wise that you also need from us, the agency, whichever way we're going. Because again, we know there's a problem. We know there's data to support it. I just need to figure out a viable measure for the residential treatment, if in fact there is one. And for IET, I need to think through what supports those might be, whether it's HIT, 42. I need to think through where those directions might go, because I have to figure out what that team might look like to support the work going forward. And as we get to moving closer to the August 31st submission date for you all, and I get closer to writing your summary, then the summary document that you'll, kind of capture some of these conversations, then I'll start helping the SUD team assemble the team to support you all. So yes, there's stuff in residential treatment I'm sure CCOs couldn't all be working on to improve the residential treatment. I just am not your SME in that space. In the IET space, I remember doing that metric, and dang, that's a hard metric. So, props for everyone working on it. And I think there's a lot of space in that metric from the complexity of it and for all of the of how it connects to a whole lot of things in care coordination, that I think there's a lot of space in that measure to do a whole lot of quality improvement work. From my recollection of actually doing that measure in an FQHC. So I'm not disagreeing that measure couldn't be a statewide PIP. I'm not sure where you all are at in that measure, having had it been and currently still is an incentive measure. So that's all I'm asking for, is kind of where you are in that measure adoption within your practices. But there's a lot in that measure. So that's, I think, where I'm asking is if in fact we pick it as a statewide PIP. I'm sure, I don't think anyone's like, hey, I solved it all, Lisa, for IET. Let's go. We're done. I don't think there is a done yet with that one, is my guess. And if so, I just need to know where you're at so we can figure out where to come to support you in that journey. Either way, even if I don't pick it as a statewide pick, you're more than happy to tell me where you're at in that one, and I'll still find some help in that space because it's still an incentive measure, even if it's not a statewide pick, and it's a dang hard measure. So the answer is yes, there's probably a punch list for residential treatment, and yes, I can get that from the SUD team. They don't need to say now what it is, but I'm sure there's a punch list. There's probably low-hanging fruit that every CCO can work on in that space. And yes, CCO should probably start working on those things in light of the SUD waiver, no matter what. If anyone has anything like Jeffrey, referrals by CCO, that would be like, if we were to do something like that, and I have others in the agency thinking about it, then that would be an additional report burden. I'm just going to put that out there. That would be an additional report burden. It's not to say that we couldn't think of that between now and, the next 6 weeks, but that would be the methodology at which we do that data collection for the for your validation, because obviously there isn't that mechanism now for collecting that data. I want CCOs to think through that, and you'd have to give me your opinions between now and the next meeting that we have about what your thoughts are on that level of interest, because that's how, if the agency picks residential treatment, and most likely it's not going to be a claims-based reporting. So let's just assume residential treatment. If I pick residential treatment and OHA picks it as the measure, then it will most likely not be a claims-based reporting. It will be a member level, somehow CCO reported mechanism, not claims-based. Then I need each CCO, and whether I fill a survey, maybe I'll fill a survey. Sarah, hopefully you're Sarah, not Sarah Kleinschmidt, Sarah Edelhart, you're writing this down, because we'll need to field it, because most likely that would be the method at which we would do data collection on a referral measure. It could be referrals by CCOs, and that would be the only way we could do this residential treatment kind of measurement, because we can't do beds, we can't do claims-based, can't do workforce. We've excluded a whole lot of other options. So unless you have another idea, let me know, and I will put that back out there. Kat, do you have a magic measurement? Because I've asked around. What do you got?
I don't have a magic measurement, but
but you raised your hand.
I'm just I really want us to choose patient-oriented outcomes that matter. And I guess I'm hearing the conversation going toward a referral measurement that's not capturing, are these the right people who are being referred? Is the capacity meeting the demand? Are people actually getting the care that they need? And it sounds like we would need to build a whole system for capturing referrals and tracking, but it doesn't tell us if patients are getting better care. And so I would worry about that.
Dana Peterson, our subject matter expert related to SUD, she wanted one that captured electronic health record data, but we don't have that either. So she wanted the same thing you wanted, Kat, but we don't have the EHR data that she was asking for. So unfortunately, she too was asking for that, but that was even further from metric viability, unless someone knows something I don't. And MOTS data system is not there yet. And the other behavioral health data diagnostic system is a couple years out. I already checked on that too. So MOTS is a no. The other diagnostic for behavioral health system is a no, for kind of a baseline assessment of where behavioral health patients are. That's at least 1 to 2, well, at least one, probably more 2 years out.
So sorry, can I just clarify? So then
Mhm.
the working potential proposal is measuring referrals to SUD with the goal to be to increase them or residential, or what would the goal be?
Well, no, I have, I also have, I'm saying most likely what I'm saying, that's an example. I have staff in analytics thinking about it as well, but I'm saying if in fact residential treatment is selected by OHA, it would be most likely a CCO specific reporting versus a claims-based reporting. I don't know what that measure would look like. I'm checking with actual OHA analytics staff here shortly. They're actually been tossing around some ideas the last few weeks. So referrals just happens to be the example that Jeffrey gave today. I'm not saying that's it, but most likely it's not claims-based, that I know. So once I actually land with analytics, probably later this week, or I think it's sometime this week, and if they have come up with a viable, potential viable option, not fully spec'd out, then I'll be sending it out to you all. And then I'll say, here's the options, not fully fleshed out as a measurement, but it's still probably CCO reported. Again, not claims-based. I need to know what your thoughts are on that. And then our options are that versus IET. And then I'm going to ask you what your IET current state is. And then I'll probably talk to leadership and go from there. Does that make sense? I got a clap, I think, from Cassandra. Kathy.
Yeah, I also would just say that if we're really looking at the waiver goals, SUD waiver goals, and we're trying to do a claims-based measure, outside of initiation engagement, you know, the waiver goals really speak to reducing readmission rates, which can be developed through claims and has been done in the past. So if we're trying to make this kind of connected to the waiver goals and something we can do that is more validatable and has a metric associated with it, I think that those are two areas that just seem like there's maybe an easier pathway to get a metric for.
Yep. Referrals to SUD programs, yeah. It'd be hard to say, would we want to see referrals going up or down, because, well, the other thing is we want to see the patients in care. So I guess if you're counting them going in, then it doesn't matter if they're going down. Okay, any questions? So the date you have is August 31st, is according to the work plan that's put forth by the External Quality Review Organization, HSAG. So that's the date that you will all have to submit for your EQR validation. So what will happen is sometime mid-July, you'll get a summary document that will talk about the conversations from March till probably mid-July. But again, you don't necessarily copy and paste that. You say, you know, I filled out a survey. I talked within my CCO about here's what we're doing with any one of these conversations. And then you will submit your design documentation to HSAG by August 31st. We have at least another conversation with you all CCOs sometime the 4th week of this month. And then I will be talking with internal OHA staff, analytics staff, and the waiver leadership team and SUD teams. They were all at a conference last week, so I just wasn't able to talk to them. They were actually at an SUD actual conference, so hence I wasn't able to actually talk to them ahead of this meeting. So I will talk with them, see where their direction and focus of where they want the Medicaid waiver to go for this. And then ultimately my goal is to have direction, honestly, by 4th of July, which means we have to have the topic population. We did hear from the CCOs, and this is just to round out residential treatment. We did hear from the CCOs that they did not want to necessarily focus in child adolescent residential treatment versus mainly around focus around adult. The agency, I haven't been able to touch base again with the SUD team since then, so I will relay that to our internal SUD team when I see them this week. So right now, the population still at this time is adult and child adolescents, but I will give the internal team, the CCO's feedback. And then again, like I said, we're exploring both tracks, IET, and then the residential treatment track based upon the April survey. Then most likely what you'll have is if in fact OHA was able to come up with a viable measure that can meet the CFR protocol for PIPs that can be done at the CCO level, that meets kind of the requirements of, numerator, denominator, population size, et cetera, from a viability point of view. Then I'll put forth that in kind of a survey plus minus delta kind of conversation to you all. And then ultimately OHA will make the call between the two topics based upon kind of the direction that OHA and the system where it's kind of current state of that. Any questions? And then yes, we'll kind of round it all up with some SUD SMEs after the next meeting, and either way we'll kind of solidify the direction at the next QHOC, which is obviously where we have the broadest attendance. So we'll see you all on July 11th, probably for most likely whatever the announcement is my guess. Well, definitely by the August meeting for sure. We're going to go ahead and transition to the next topic, next slide. And I'm going to do a participant check. Caitlin, are you on the line? Caitlin might be early. Let me check. Jill's on the line. Hi, Jill. Jill, do you know what time I told Caitlin?
I think you said 2
early?
o'clock. I think you said 2 o'clock.
Okay. Well, I'm going to go ahead and get going. Why don't I go ahead, Jill, why don't you go ahead and introduce yourself while we're just kind of maybe waiting for Caitlin. I'll see if Caitlin's going to be joining here shortly.
Hello, everyone. I'm Jill Hudson. I'm a principal at the Reed Group, and we have been working with OHA on the National Diabetes Prevention Program, the Medicaid benefit evaluation, and now we're working on implementing and considering evaluation results to look at changes in implementation to improve uptake of the benefit.
Great, thanks, Jill. And there's someone from public health who might be joining. Her name is Caitlin Lyle. She's a policy analyst within the Health Promotions Chronic Disease Group within public health, and she has been on the grant within the CDC National Association of Chronic Disease Director for some time, but I have been part of this since the beginning. So I'm going to go over a few slides about this, and then we'll have some open dialogue about some of the technical assistance needs that you might need, which will help inform the next phase of this. So let's go ahead and go to next slide, please. So National DPP in Oregon. So back in 2016, our Medicaid director at the time, Lori Coiner. So Lori was here as the Medicaid director. She left, she came back, and she left. So Lori Coiner, with the National Association of Chronic Disease Directors and the CDC, basically signed Oregon up and basically said, hey, we are going to align with where the evidence is at, and said, we're going to test the national DPP in our Medicaid population. So we were one of 2 states in the US that basically tested the DPP amongst Medicaid. And we received that actual funding, and we tested it for 2 years. And we had, as part of that funding, also worked with the Health Evidence Review Commission and added DPP as coverage within the actual prioritized list. In I think, what was that? HERC added to DPP in 2018. Then ultimately, in 2019, the HERC added DPP as a covered benefit for the diagnosis of obesity as well. So obesity is an additional diagnosis. So National DPP has covered diagnoses that have certain criteria, but now obesity was added in 2019. Then in 2020, pandemic hits, and it, you know, adapted DPP to be pretty much all virtual. Then in 2021, we contracted with the Reed Group, you just met Jill, to do an evaluation of the DPP benefit. DPP is implemented within Medicaid as well as in our fee-for-service population. So what you'll see is some of the results about DPP, not just in the CCO world, but also through our fee-for-service. Next slide. So specifically from the demonstration. So first off, in the demonstration, we had 3 CCOs that started the demonstration. We had Family Care. Yes, it goes back to the dates of when we had Family Care. We had Health Share of Oregon, and we had Trillium. The demonstration project showed that 4.5% members of the demonstration met the criteria of weight loss. We had total number of sessions attended significantly associated with that weight loss. We had actual kind of data that showed online versus in person. And we also had Health Share who implemented it kind of with equity in mind, equity principles from the get-go. So what we showed from the very beginning of the demonstration is, along with Oregon and Maryland, which was that yes, DPP can be implemented in a Medicaid population. DPP had evidence from the Medicare populations, and that's why this demonstration was really important from a Medicaid population side of it. Can it show that Medicaid populations can show the same evidence? The answer is yes. Next slide. Current state of DPP and current state, just recognizing that it's from the spring, so earlier this year. Utilization and billing of national DPP and Medicaid beneficiaries is relatively low for us right now. We have 3 CCOs currently reimbursing. Again, this is about, again, lower. So this was in 2021. Some of you all, I know, are actively working on it, and this might have changed, as in might have changed in the last couple of months. 6 organizations, 2 tribal health organizations are billing CCOs. Notably, the majority of our recipients who are billing national DPP are served within tribal health organizations. Next slide. And again, that tribal health is again through our fee-for-service and CCOs. This is some of the slides from the Reed Group's health evaluation. So let's go ahead and go next. This is just to set the stage for the conversation. The Reed Group, through their evaluation that was conducted in 2020, really did kind of go through and do a thorough evaluation. Sorry about those pop-ups. They did 27 key informant interviews. They implemented surveys, and thank you all to the CCOs. When I asked for who should be your DPP contact, now you know why I asked for who should be the DPP contact, because you were contacted by the Reed Group. They contacted CCOs. And they contacted DPP referring physicians. They contacted DPP providers. Next slide. Current challenges with implementation of the national DPP benefit in Medicaid: awareness. Many key stakeholders were unaware, or many partners were unaware of the national DPP Medicaid benefit. So just that it is a benefit. There are several resources, processes, and requirements that are difficult to navigate. There's poor retention of Medicaid beneficiaries in the benefit. So again, it's a long program. Fee-for-service rates are below cost. Limited reach to Medicaid beneficiaries and the uptake of the benefit. Lack of targeted recruitment. and limited data on DPP Medicaid benefit in Oregon and its associated data systems. So again, this is kind of a culmination, just the high points of the actual evaluation conducted by many of those surveys and focus groups and conversations that was on the preceding slide. Next slide. So one of the things that we wanted to do, let me just quickly check to see if Caitlin's now on. Great, because we want to make sure that Caitlin, who is again in our public health group, as we're looking to partner with our public health team going forward, basically we receive funding from the CDC and National Association of Chronic Disease Directors. And what public health and the Medicaid office here at OHA are looking to is to talk with you all as CCOs and find out what resources you all need from us, and discussion of really what's the opportunities to, well, we can have the barrier conversation, but which is a whole nother conversation. And we'll probably have a facilitated learning collaborative at some point, because we know there still are kind of lots of hurdles with billing, and there's different pathways of funding. We all know that. But we really wanted to have a conversation of the technical assistance needs. And the reason why we need to have what technical assistance support does your CCO need, because we need to think through what the funding opportunities we have and the budgets that we need to put forth to our funders. So Caitlin here from Public Health was wanting to talk to the CCOs, you all, about what that might look like. So as we construct our proposals to our funding agencies, whether that is, you know, I'm just rattling off things, and Caitlin might be like, Lisa, what did you just say? Whether that's mini grants, whether that is like an actual learning collaborative outside of QHOC, whether that's, whether we do like because we used to do like these little mini search things, or whether that's we send Jill out to your CCO, I don't know. Those are the kinds of things that we're trying to think through. What do you in the CCO need to help move DPP forward, and what that might look like? And there is no wrong answer. We're just trying to brainstorm how to best provide the technical assistance so then we can inform our funders. That's how we're designing the technical assistance, because we actually ask the CCOs what they want. Is that pretty much it, Caitlin?
Yes, yeah, thank you, Lisa. I think that sums it up nicely. Essentially, yeah, I would love to hear from you about what would be helpful in terms of technical assistance supports. We've talked internally about kind of a variety of things, as Lisa just covered, but really interested in knowing that it's been, I think, a busy couple of years is an understatement. So knowing that we have some funding available, and of course are interested in supporting you all, what actually would be helpful, and having just a kind of period of time today to brainstorm that together. Knowing that this is not the only engagement opportunity or opportunity for feedback, but really, I think, a start of a conversation. So yeah, with that, would love to kind of open it up and hear from you all about what technical assistance support would be helpful, thinking about really the next 6 months to year or so of National Diabetes Prevention Program implementation for the Oregon Medicaid population.
I have a question. This is Chair Zalenbaugh, and I'm from Pacific Source. My question is related to virtual diabetes prevention. There has been some back and forth related to CDC requirements no longer requiring a fitness tracking device. And, you know, those costs are really right now driven out of flex dollars for us. And so if that was eliminated for the requirement for billing, then I think we would be able to implement quite a few more. So, and I know there was someone checking for us to see if you guys were going to align with the CDC, and is that in progress, or has there been any decisions made around that?
Yes, so we can get to those very kind of tactical questions about, like, is the benefit going to cover this or not cover this? Jennifer Valentine, who is on the line, but I'm taking those notes down as well, which is which is good to know as well, but I don't think we have that answer. But that gets to the question of, there's a lot of in the weeds billing questions, which leads me to, is billing support a thing? I mean, I know it's a thing, but is that a consistent need across CCOs?
Yes, at least this is Bethany with Columbia Pacific. Yeah, I would say for us, contracting with CBOs to provide DPP, that has been something that we've struggled with, or at least have had to kind of come up with in a patchworked way. So billing support would be appreciated. I would say specifically to the last question around virtual support, guidance from OHA on how to sort of leverage the online solutions, given that there's limited recognized organizations that deliver DPP in rural areas. So any kind of guidance around leveraging online support would be awesome, or online solutions would be great.
Thank you, Bethany. So is it, and I'm just going to continue to kind of probe these questions. So, so there's the contracting piece, so contracting with virtual CBOs potentially, and leveraging those CBOs in a capacity that allows them to deliver in rural communities. That sound about right?
Correct. Yep, you got it.
Okay. Okay, so I got 1 for 1 there. Now, we don't need to get into so sometimes with the contracting, after you get the contracting part, there's I don't even know what you call it, the cohorting, you know, the critical mass. You got to like have so many people to be able to have a session. Has anyone faced that problem as a technical problem? Or we just haven't gotten there yet as a problem? I'm going to go with, it's not a problem, or we don't know what we don't know yet on that one, Jill.
Yeah, this is Bethany. I'll confirm it. We don't know what we don't know yet.
Okay, because basically once you contract with the provider, one of the issues might be, and this could be whether it's in person or virtual. Sometimes when you contract with the provider, so I'm going to be, I don't know, I'm the CCO and Caitlin's the provider. I pay Caitlin, but Caitlin doesn't want to hold a meeting for just Jill, right? Caitlin wants to hold a meeting for 10 people, not just for Jill, because Caitlin doesn't want to sit there with just Jill, right? She wants to get paid for 10 people. So Caitlin's like, thanks, Lisa, for the contract, but I need more than just Jill at my one, you know, my little session. So she's going to just be like, thanks for the contract, but I need to wait till there's more than just Jill. So you might first get past the contract period, but then you need to get to the cohort. And that's when one of the barriers that were mentioned was, I don't know, I call it cohorting, but it's where you have to reach a critical mass of engagement of your Medicaid population that needs to get scheduled to Caitlin so that she can have 10 people scheduled, not just Jill. Does that make sense?
Totally. And I would say that I'm not aware of that being an issue for us. And I think our numbers are so small that I don't believe that there's any kind of cohorting requirements from our contracted provider, just given that the numbers are so low, we wouldn't have anybody if that was a requirement.
Okay, great. So from a technical issues point of view, so far contracting is still a barrier. is how to use the technical guides that are out there still an issue? Like, going through the guide, do I use health-related services in lieu of services? Do I use my medical spend money? Y'all know how to do that, or which one you plan on doing?
This is Ashley from Pure Oregon under Health Share. I would say that the CBO side of that, I would say that's an area we've talked about all the various possibilities underneath that. And there's still, even if we thought about, let's say, flex services as an avenue, there's still some reporting elements that are difficult. So I think we would really appreciate some technical assistance around that specifically. Because even when we've read through the guidance document, we still have lots of questions if we're trying to move away from, if we're trying to get more at a payment at an individual level versus at a community level, which we're not against. I think we're just kind of looking at all the options, but I do think that we could use some guidance on that type of technical assistance and what other people are doing. Because I am curious if a lot of CCOs that are focusing their investments at a community level, like CBI, but we know with some of our CBO partners, some of the requirements, if we wanted to use flex or in lieu, there'd still be reporting requirements. And so there is still some question of admin burden and process that we still need to figure out.
So it's the reporting requirements associated with the different funding pathways.
Correct. And just really like how CBOs would really feel well supported and not being put into a medical model. Does that make sense? I feel like this is the question that we've been asking in various settings too. But so I think that would be helpful.
So reporting requirements with the various funding models, and I guess first and foremost to that, which way the CBOs feel is the least, which way supports the CBOs in the most equitable, accessible manner.
Yes. Feasibility for them.
Feasible. Yep. And then after all of that would be how, and I don't know if this is even possible, but how and what other manners in which the other CCOs are doing their design methods for this particular benefit. Now, that may or may not be proprietary. I don't know. I'm not a CCO, nor am I in the finance world of that. But that's what I think I hear you asking, because there could be some lessons and opportunities in sharing about how each CCO is doing on that to, learn about how to reduce administrative burden in any one of those pathways.
Yes.
Okay.
Yeah. I mean, you don't have to give me the nuance of tell me what you're paying, just what process are you following using the guide as a document? Just because I'm curious, the spread and depth of how people are focusing their efforts. Because for example, we have some health system partners who are billing us because they have the billing infrastructure to do so. It's just, again, the other side that is in some of our regions, it's only community-based organizations that offer it. So again, it's kind of that to me is again how I'm really my focus for how other CCOs are approaching that.
I have a comment from our fee-for-service team in regards to that fitness tracker device. So I'm just going to read it verbatim, and then we'll go from there. And I believe it was going to be updated in the online in the DPP guide, and I'm just not sure if it has gotten updated, but I might as well just put it in here. Fee-for-service does not require a fitness tracker device, but fitness activity is supposed to be reported to the program weekly, so it'd be able to be in alignment with CDC. OHA never required a Fitbit type device, only that online DPP has a place in the online program to submit that information to the program. So basically, the CDC has, a spot for it to be, it has its spot for it to be collected from the DPP provider, but the actual device is not required from a fee-for-service program, and the patient can self-report that to the DP provider, and the DP provider can upload that information through, you know, the means at which they report a whole host of data like weight loss, etc. So,
You just
in other
made
words,
my year.
did I?
Yeah.
Well, look at that. You know, let's just call this meeting over. I'm done. And if you need us to put that in email, you can drop me an email and I'll document it. But I know, I actually remember this meeting, Jennifer. I know I had this meeting, and I believe someone was going to be updating it in a guide. So we'll make it official in the guide. But if you need me to write that in an email to Sharice, I can do that. Just drop me an email and I'll put it in your email to make it official for you at least. But someone will be updating on the actual guide itself. Oh, and it actually went out to CCOs a while back in an email or something. Something happened to CCOs somehow in a memo, but there you go.
Well, I apologize if I missed it, but thank you for the
You know what?
clarification.
It probably went back. It probably went to your ops people from Dave and Body, so it just didn't make the rounds to the right, you know, to the ethers of all CCO staff. Thank you, Jennifer, for that reminder. What other kind of technical assistance? And now let's think about the methods at which you want the technical assistance. Is that helpful, Caitlin? Not just the kinds of technical assistance, but the how they want the technical assistance?
Yeah, that would be great. I mean, I'm hearing a lot of opportunities in terms of like OHA as guidance, but translating that into practice, there's a lot of, I think, potential supports or TA needs there. But thinking about like another process and delivery, knowing maybe different organizations and CCOs have different, you know, preferred methods, but thinking about if it's a facilitated learning collaborative like series to really dig into some of these nitty gritty questions that folks have. Is it really to have CCOs come together and share kind of the processes behind how they're implementing the benefit and have a shared learning space? I think there's a variety of different ways that we could kind of take this. And so curious about kind of, yeah, the methods and the like how you'd like that technical assistance delivered, because historically we've done written guidance documents. We've had a couple webinars that have been hosted about a year and a half ago or so. And so kind of see a lot of opportunity moving forward to support, but opening up for the types of kind of delivery methods would be preferred to receive that TA or support.
Do you think you want it during an OHA QHOC meeting? Do you want it outside a QHOC meeting? Because again, I appreciate having so many people on this call. I think by just sending out to your medical directors and your quality leads saying, hey, whoever is doing DPP in your CCO, please invite to this meeting, which I love seeing new faces and new names. So appreciate you all joining. But is that, you know, do we have a DPP learning collaborative outside this meeting? Do you think it's a webinar or a go-to meeting? What are y'all feeling for this technical assistance?
I wonder if a DPP specific meeting would be appropriate. I can say that I don't generally attend this meeting and have only attended to talk about DPP. So if it was outside of this meeting, just so that others' time is used wisely, then I could see that being more beneficial.
Do you feel that having CBOs, do you feel that it should be audience specific, so CCO specific and then CBO specific, or do you think combining is good? We've done it both ways. I'm just throwing things out there.
I could see the conversation perhaps being more fruitful if it were both.
Is there a time of year that says, no, don't do it?
Not Q4, probably.
Ashley, I agree with you, not Q4.
There's a lot of reporting due and just holidays, and yeah, it's hard. Q4 is hard. And I apologize, my computer blipped right when you were talking, Bethany, for your suggestion. So something I was thinking about, I do think having a combination, but also if we're really getting around pathways, if there's specific like contracting, reporting, I think that could be helpful to have CBO guidance in that. And also it could be helpful, I don't know, I'm trying to think about like, would it be helpful to also have CCO time to just really like get through like some barriers and weedy conversations, and having people from OHA that could really answer those questions too. I'm not sure, like keep going back and forth, and like I want to honor people's time that are participating too. So when it gets to like contracting and specifics, I think there could be two conversations, like meeting with CBOs and kind of hearing what's happening, what's working, and then figuring out the problem solving after hearing all of that, or how people are addressing them. I don't know. I'm just trying to think about honoring the time of people at the table, and then also if there's CCO specific stuff, when to have that, so it's not like wasting people's time.
Well, it could be both. I mean, there could be, I mean, equally so, it could be that the CBOs might have some, so I mean, I'm potentially envisioning, I don't know, I have no idea, Caitlin. I'm just now just thinking out loud. It could be that we have, I don't know, a half day, I have no idea. But we have it as a group, and then we have breakout, and the CCOs get time with Jennifer Valentine, who is, you know, our brainiac with billing stuff, and she's our fee for service person that knows a whole bunch of codes and a whole bunch of things. She's the one that told us about the device, right? So CCOs be like, hey Jennifer, what about a bunch of codes that I don't have memorized, but Jennifer does, and then the CBOs get Caitlin time, and you know they get, you know, I'm making it up, I'm throwing a Nona under the bus, you know, a Nona time with, you know, in lieu of services time, right? And we OHA bring the resources of whomever these individuals are that have the expertise in these specific arenas, whether it's technical billing and codes and stuff, or whether it's barriers around connecting with CCOs and communication and patient engagement and all that other stuff. I mean, it could be both group time and then specific time for each one to make use of everyone's.
Yeah, and I'll also add that there's definitely been interest from community-based organizations and delivery partners to meet with CCOs to actually a lot of the same kind of technical assistance needs you all identified a little bit ago are kind of same on there in terms of contracting, CBOs and CCOs working together. And so there have been kind of explicit interest from community-based organizations to really have a role in helping to support kind of this next phase of implementation of DPP. And so they're not just willing, but really excited to be at the table for these conversations. And so I think a lot of opportunities with how we structure that, but knowing that from their perspective as well, they're interested in engaging as much as possible in these conversations so they can, of course, you know, get paid for the work that they're doing, but really about supporting their communities and accessing these services.
Great. Caitlin or Jill, can you think of anything else that might be useful as we're thinking of and that we need when we're talking with our funders and developing the next year's kind of plan?
No, nothing. I mean, this was really helpful to hear. And then also just to express this is not, I think, the only time to share. So if after you leave this meeting, you have additional ideas, feel free, please, to email us, reach out to Lisa. This is, like, again, a starting point, and we would love to hear additional feedback and ideas you have, both around specific technical assistance needs as well as the delivery of that. Just so, kind of to Ashley's point, we really make best use of everyone's collective time, knowing that everyone's extremely busy and really wanting to support you all in this. And so please continue to reach out as things come to mind, beyond this meeting as well. And we welcome any and all input there.
Great. Well, then we will continue to field it. As DPP goes, as we come out of a pandemic, yes, we're still in it, but as we start to get back into whatever world looks like after COVID, and, we had no COVID update today at QHOC, which I just will make note. It's been 2 years and I didn't have a COVID update. I will just say that, knock on wood. So we'll see what next month looks like. But as we start to come out of this world, we'll start to kind of bring us back into quality improvement. We will see where we can bring DPP into preventing and going more upstream into the health and diabetes prevention. Obviously, is evidence-based. We're trying to prevent our fellow citizens becoming diabetic, which we all know where diabetes takes you. Takes our health system, takes our care, takes the cost. It's not a place we want anyone, including my mother-in-law, actually. So it is something. Which, by the way, diabetes prevention in California, I have to say, my mother-in-law's in California. They have diabetes prevention posters in Vietnamese in her clinic, which just cracks me up, because I'm like, I'm trying to do diabetes prevention in Oregon, and yet I have DPP in Vietnamese on the phone everywhere. I'm just like, if I only knew how to speak Vietnamese. But I do see DPP, because that you can kind of like understand, which is kind of crazy. But we will continue that journey here in Oregon, and I will continue to support it. And we will figure out where and how we can work on the technical assistance in the coming year to support you all in the CCO. So thank you for joining. I know for many of you who haven't joined QHOC, thank you very much for joining and sharing what information we can to help support you in the next year. Caitlin and I and Jill will come back with some form of resources. We don't know what that will look like, but we'll come up with a plan. That I know. And I will. I also like to get the word out. Yes, I think that exactly is correct, Cerise. We have to think about what that engagement to members look like. But I think Caitlin, and we'll work within. It's hard. We have to try and think through that with a whole lot of things in care. Diabetes prevention being one of those, but just like we talked about with our learning collaborative, immunization being another thing, a whole lot of upstream prevention care. How do we communicate with our members to try and engage them in their care is just, it's an arm, it's a strategy and intervention I'm trying to think through holistically, and which populations and which part of their care we're trying to communicate. So I agree. I'm not sure how and which where go, but we'll see. Another thing to think about is community information exchanges. So I've got a lot of great comments that Caitlin, I'll try and share with you as well, that feed into how we think about this technical assistance. So remind me to share that with you. Thank you very much, Jill and Caitlin, for joining. We should probably schedule a debrief before we put forth our next budget conversations. So, bye.
Thank you, Lisa.
Okay, thank you. For those who are, and Laura, let's talk about the next part of the agenda, which is just items from the floor. Next slide, I think it just, I don't even know if it says items from the floor. Any suggestions for July or August for the QPI session. I know one of them we were going to be talking about, like I said, the TQS projects. If you have a suggestion of whether you want it to be July or August, most likely, then send that to Laura as far as which peer learning you want that to be. Any other topics you want Laura or I to consider, then please put forth.
Boy, lots of quiet people.
I think they want you to pick, Laura.
Oh, if I had to pick a quality topic for next month, I don't know.
Well, I think you and I are talking this week, so you have until then. No.
Well, I was going to go back to, you offered me up dancing one session. I was thinking having you dance.
Oh, that I can tell you is not a good scene. That is definitely not a good scene. It's bad. It's really bad, actually. So I can give you guys all testimonial from many people that should not be allowed ever on camera.
So Lisa, one thing that we haven't really talked about at QHOC is MEPS and the work that people are doing around their MEPS projects.
Yes, people did. I missed a MEP meeting back at the end of May because I was sick. But we can. The MEP people, like it sounds like there's people named MEP. They presented MEP projects at a MEP meeting, which I was really looking forward to hearing. But I was sick. So here's some topics I'm going to put in the chat for everybody. And I guess I can, there's language access. Jenna just put one, MEP. Real D update, language access, TQS. So what I could do is, Laura, we can do a poll if you want, or I can, I could put a poll out, or people can put some stuff in the comment like Jenna just did. One of the things is that Real D update. Basically, that was a continuation from the conversation this today during the Learning Collaborative, which was to give you a little bit richer, deeper dive into the deeper dive dashboard, where the agency took a whole lot of data sources and this is the official term, we meshed them together, and made my, like if Lisa Bowie is Asian in one data source, but Lisa Bowie in another data source was blank, and then Lisa Bowie in another data source was white, or blank again, we took it and said Lisa Bowie is Asian, because in one of 5 data sources, I was Asian. Then for that deeper dive dashboard, we reconciled Lisa Bowie from 5 different data sources is Asian. That's what Sarah reported in this Learning Collaborative data set that was referenced today. So part of that Real D update was talking about the glide path or the trajectory of where the agency is trying to go with trying to improve that unknown data set of race and ethnicity data. And so you've heard about it once, but we can try and get you another update and or give you some of that information about the deeper dive dashboard. So I can try and tee that up for an afternoon as well. And Jenna, when you say language access, do you mean the measurement, or do you mean like technical assistance? What are you thinking? Or do you mean both?
I was thinking more systems. I mean, I think there is a ton of conversations about like how we make the metric go, but I think from a QI perspective, like there's so much, there's so many system-based pieces that I don't know, that they really apply to the network more than the measure and how many, you know, quality or the qualified or certified, you know, the claims-based pieces that the measure is based on. And maybe it's just us, but it's really it's really this more of the system and structural work around that. So I guess it would be more TA.
Okay.
But more on systems, not on how to capture the, you know, the claims or the invoices for interpreters.
So again, it's not like the reporting, and it's not the claims. It's how to improve your network of. Are you talking about like?
I think I'm talking everything. How do we improve relationships in those systems around vendors? How we work within the provider, you know, space around some of it is tracking, but, you know, how we support providers in all of their systems, like how they use you know, like iSpeak cards and communication and the resources that are available. Yeah, it's more of like the system transformation pieces around language access that are needed, not just how to track it.
Yeah, there's also there's different ways to use the engagement piece of the actual, there's a whole lot you could actually try and do with that. I'm just going to take some notes before I forget them. Hang on.
And a lot of that transcends not just the measure, but the health equity plans that all CCOs have, as well as the TQS, because there are those cultural, responsive, and class activities as it relates to TQS, you know, components. And so it really is bigger than the metric, although I think it is part of it.
It is, yeah. I'm going to jot down some notes, but I'm not sure. I'm actually not sure if that's really honestly an afternoon session. That might be actually a learning collaborative. I mean, it could be both, but okay. What are other people's thoughts? Any other topics? You guys want to talk about your mental health access tip and what you all are doing around that?
Hey, Lisa, this is Cassandra again from Pacific Source in regards to the mental health access PIP. I know we have our next submission due on July 31st, but are the statewide PIPs on the same reporting cycle as our non-statewide PIPs? So are we going to have to do like a Q3 report, even though we haven't got back the validation yet for the July PIP?
You'll have to submit your on July 31st. You'll submit your validation, your EQR validation. You won't submit it quarterly.
But when will the next submission be due after July?
October 31st.
So, I mean, I just had a question on that because of when we look at the timeline for when we get our actual feedback from HSAG, it kind of crosses over with Q3. So I wasn't really sure how we're supposed to handle that.
Let me check in with HSIG when you get your feedback. Do you have that right in front of you? I don't have it right in front of me.
I don't think I have
HSAG,
it
are you
right
on the
in front
line?
of me. I think it's like, I think when we get it back, it's like, I think when we get back our validation scores, it's like 931. And then we have an opportunity to resubmit, and we get this back in November. So if we're submitting Q3, we don't even we haven't even really received back the results for.
Let me
presented
check in with
July.
HSAG. I have a check-in with them in a couple, like maybe a week. So I will check in and get out guidance. And I'm sure someone from HSAG is possibly listening, but if not, I've written it down. So I will send out an email. Let me just check in HSAG. Confirm. Someone also just put in potentially some cost growth target update connection points, potentially to QHOC, whether that's at this meeting or another, whether this QPI session or in the morning session. I will think about that. Thank you, Krista. I'll probably kind of put that in the morning session. But yes, I think kind of connecting on where the cost growth target measures are, and they're not going to be at the CCO level, but just being aware, just very similarly so, where the MEP work is going, which is at the CCO level, but being aware of where the cost growth target work is going will be also helpful, I think. So I put that on the list as well. Well, I think this gives enough for Laura and I to consider. Laura and I are checking in later this week, actually on Wednesday, Laura. So we can tee up what will be for July, and then we'll circle back with y'all. So have a good rest of your afternoon. You will hear from me for SUD statewide PIP at some point, hopefully in the near future. I will talk to the analytics team, the SUD team, now that they're back from their conference. We have an external SUD team or external SUD statewide PIP meeting next Wednesday, the 22nd. So at the very least, some of y'all are going to be on a meeting with me next Wednesday to talk and get the most recent update from the agency on the SUD design phase next Wednesday, the 22nd. So have a good rest of your afternoon, and we'll talk to you all later. Thank you.